Good morning and welcome to the 7th meeting of the Health and Sport Committee in 2020. We have received apologies this morning from Miles Briggs. I would ask everyone in the room please to ensure that mobile phones are off or on silent and not to use them for recording proceedings or photography. The first item on our agenda is a panel evidence session on the Forensic Medical Services Victims of Sexual Offences Scotland Bill at Stage 1. We've received apologies on behalf of the Chief Medical Officer, who is unable to attend as she is required at Cabinet, but I'm looking forward to hearing from our witnesses this morning on her behalf and in relation to the bill itself. It will give us an opportunity to hear about the work of the task force for the improvement of services and about the provisions of the bill. Can I say, in relation to coronavirus, which is the reason why the CMO is unable to be with us this morning, the committee is not looking at that today, but of course recognise that it is of central importance to us and to Parliament and to our constituents, and it is a matter to which we will return in due course. Can I welcome to the committee Dr. Edward Doyle, Senior Medical Advisor, Paediatrics, Greg Walker, the Bill Team Leader, Tansy Main, Unit Head of the CMO's Rape and Sexual Assault Task Force, and Katie Richards, Solicitor from the Legal Department. And can I invite Tansy Main to make an opening statement, please?
Thank you, Convener. So I'm head of the unit within CMO Directorate of the Scottish Government that has responsibility for the CMO Rape and Sexual Assault Task Force and also for the Forensic Medical Services Victims of Sexual Offences Scotland Bill. I will not cover the bill itself, but Greg Walker will be happy to answer any questions about that, about the bill process and what the bill provisions will do. So I'm going to provide a brief overview of the strategic context for this work, and then I'll briefly highlight some of the key task force achievements to date. So I understand you met with survivors last week. The Chief Medical Officer and I have also met with survivors and have heard similar, if not identical, accounts as you. Their experiences were distressing and frankly unacceptable. Indeed, it was feedback about the quality and consistency of these services that prompted Her Majesty's Inspectorate of Constabulary in Scotland to undertake a strategic review. The report, published in March 2017, highlighted significant gaps and disparity across the country and made 10 recommendations to improve this. In April that year, the CMO was asked by the then Cabinet Secretaries for Health and Sport to chair a task force to provide national leadership for the improvement of these services. The task force vision is for consistent, person-centred and trauma-informed services across Scotland. Our ambition is to ensure that the shortcomings of the past are not repeated. The Chief Executive of Rape Crisis Scotland makes an important contribution to this work and helps to ensure that the voice of lived experience is always front and centre of everything that we do. In order to deliver against the HMICS recommendations under the remit of the task force, the CMO published a 5-year high-level work plan in October 2017, which set out action across a range of issues between now and the end of 2022. The Scottish Government has committed £8.5 million to support this ambitious programme of work. In December 2018, HMICS published a progress review which recognised the joint strategic leadership across health and justice, but highlighted that challenges remained. At the time of that review, the CMO commented that the work of the task force was at a tipping point, and since then considerable progress has been made. We know, for example, that having access to a female doctor is very important for anyone who requires a forensic medical examination following a rape or sexual assault, and improving this was an early priority for the task force. Since 2017, we've provided funding to NHS Education Scotland to provide specific training for doctors with the aim of increasing the number of women available to undertake this work. This training has also been adapted to allow nurses to attend who are also involved in providing trauma-informed care for victims of rape and sexual assault. So far, 118 doctors, 70% of whom are female, and 68 nurses, 97% of whom are female, have been trained. A further 10 doctors and 21 nurses were due to attend the NES training today, but NES took the decision late last week to postpone that due to the COVID-19 situation, and that will be arranged as soon as it's practical to do so. Baseline workforce data indicates that 61% of sexual offence examiners in Scotland are now female. This is an increase of around 30% on the indicative figure that was in the HMICS report. But we are not complacent. The availability of a female sexual offence examiner is the first quality indicator underpinning the Healthcare Improvement Scotland standards, and work to continuously improve this remains a top priority for the task force and for health boards. Task force funding has also been provided to recruit more forensically trained nurses, to be present throughout an examination, and to help ensure an individual receives appropriate follow-up healthcare and support. The task force are also supporting a new initiative to develop the role of nurse sexual offence examiners in Scotland. This was a key recommendation in the HMICS report. Funding has also been provided to train a cohort of community pharmacists to look for indicators of rape and sexual assault and to provide a trauma-informed response to any disclosure. We've also begun work with the Scottish Courts and Tribunal Service to pilot sexual offence examiners giving evidence in rape and sexual assault cases remotely. Establishing dedicated healthcare facilities across Scotland was another key HMICS recommendation. Task force funding is being invested in each of the 14 territorial health boards to develop their sexual assault response coordination service in line with a national service specification. Funding is also provided to develop regional centres of expertise to support these locally delivered services. All examinations which were previously located in a police station have now moved into an appropriate healthcare setting, and funding has been provided to ensure that all health boards that require a colposcope are able to purchase one. A national decontamination protocol has also been published and is being implemented by health boards, addressing another HMICS recommendation. A package of resources has been developed to ensure a consistent national approach to the recording, collation and reporting of data in relation to these services. This package includes the final Healthcare Improvement Scotland quality indicators underpinning the standards published in 2017, a new national form to consistently capture information obtained during a healthcare assessment and forensic medical examination. This has been agreed by all key partners to ensure it meets the respective needs of the healthcare and the criminal justice systems. National data sets to monitor health board performance against the quality indicators as they progress through their improvement journey. The first national clinical pathway for adults who present following rape or sexual assault, and a summary clinical pathway for wider healthcare professionals who might be the first to respond to a disclosure. You will appreciate that we want to ensure that all health boards are appropriately supported to understand how these resources knit together and what their role is in ensuring a successful nationwide rollout. As such, my team have held roadshows in NHS Shetland and NHS Orkney just last week, and 4 more were scheduled for the remaining health boards over the course of this week and next, to explain what this change in practice means for them. However, in light of the current COVID-19 situation, we are very mindful of the unprecedented pressure on the NHS to prioritise their response to the pandemic, and are therefore considering when it would be appropriate to ask Chief Executives to implement these new measures. The Cabinet Secretary will write to the convener about this as soon as the position is clarified, and in the meantime we can provide copies of all relevant documents if that would be helpful. Lastly, as we announced in the policy memorandum for the bill, a new subgroup of the task force has been established to develop detailed protocols for health boards on the provisions of the bill as they relate to self-referral. This group's work is already well underway. In conclusion, the task force is now halfway through its 5-year plan, and whilst we still have much more to do, the impact we are making is tangible, and the bill will be an important anchor that will underpin everything we plan to achieve going forward. We'd be happy to answer any questions you may have. Thank you.
Thank you very much. That's a very helpful start. Can I start simply by referring to the language used in the recommendations that were made to you, that what we were looking for was a victim-centred and trauma-informed way of working. Reflecting on those specific requirements, and I hear what you say about more female examiners, examinations on health board premises. These are all obviously important. But over the piece, how do you feel that the work of the task force is contributing towards that end?
As I say, I think we still have a lot more to do, but we have come a long way. I think prior to the task force, health boards were already delivering these services in many areas under the Memorandum of Understanding, and in many places they were happening in a police station. A lot of staff were not trained in trauma-informed care. Colposcopes weren't always available. And the work that we've done over the last couple of years has really been to, first of all, our priority was on ensuring that we moved into appropriate healthcare settings. So the national specification document that I referred to has been published and sets out the requirements for age-appropriate person-centred surroundings. And whilst they are in a healthcare setting, the emphasis is very much on ensuring that it's as homely and as person-centred as possible, that it feels as to minimise the kind of clinical environment as possible. The suite for the forensic examination itself, you'll appreciate, because that has to be decontaminated, is understandably clinical to an extent, but the other rooms and space in these suites are being designed to ensure that they are as comfortable and a supportive environment for people as possible. And the other key part of that is ensuring that these are kind of a multi-agency approach to the setting. So Health Board's been working closely with their Police Scotland partners, with their local rape crisis centres and other key partners to develop that multi-agency approach so that a survivor can have their forensic medical examination, they can meet their rape crisis advocacy worker in the same place, and then they can give their recorded interview to the police in that setting, and then they can shower, they can get fresh, clean clothes. Little things that we know are really important from feedback from survivors, having access to a cup of tea and something to eat, and some time just to some space to talk to someone before they leave. All these little things are helping to make a big difference. Health boards are all at different stages in that, but I think overall we have made considerable progress. And one of the Chief Medical Officer's first asks of Chief Executives was to ensure that all doctors that are involved in providing this care have undertaken the NES training, and the training was specifically designed around the principles of the trauma training framework. So the majority of all doctors and nurses involved in providing that care have done that training. So that again will make a big difference in terms of the person-centred care that's provided. From
what you said, it's clear that the views and feedback of survivors are informing the work of the task force. Is there a formal read-through in any way from the witnesses that you receive, the survivors of rape? A formal route, did you say? Yes, so Sandy Brinley, the Chief Executive of Rape Crisis Scotland, is a key member of the task force, and we have a survivor reference group, and there's been a number of things that Sandy has very kindly taken to survivors to talk to them about the task force's work and to get their views and opinions on things. One of those most recently was the generic name for services in Scotland. So you might be aware that in England their services are called Sexual Assault Referral Centres, SARCs, and we thought long and hard about what was appropriate name in Scotland, and based on feedback from survivors, the agreed name was Sexual Assault Response Coordination Services, with the emphasis on the response and the coordinated multi-agency aspect of the service that we're trying to provide. We also sought survivors' specific views on the service specification that I mentioned, and how that describes creating that person-centred environment. So we do have that formal kind of channel to survivors, but in addition to that, Catherine has met with survivors directly, as have I, and their stories and experiences have been invaluable, and actually, you know, they are touchstone in what we always come back to. Of very early days in this post, I met a survivor who had had an appalling experience, and she spoke very bravely about that, and how it wasn't person-centred or trauma-informed at all, and those stories, you know, we keep coming back to and thinking, how will what we're doing make a difference for those people, and so that they're not repeated again. Thank you very much. Sandra White.
Thank you very much, Gavin, and good morning. Just a supplementary on what Tansy had mentioned. You mentioned about healthcare settings and spoke about that. Obviously, our evidence and the actual practice that's going about doesn't seem to match what you're saying is available to people. So I just wondered how many of these healthcare settings that you're talking about are actually in place. Is there a timescale for them? Because certainly what we were told was people were sitting in police cars, people were sitting in police offices, they couldn't change clothes, they couldn't get a drink of water, they couldn't even go to the toilet, all of that stuff recent. So I just wondered how many of these healthcare settings with ongoing support are there, and when are they likely to come about? If there's, how many is there, and do you do an evaluation on how many and what the service actually provides to people from the survivors?
Certainly. So we work very closely with all the 14 health boards. Each board has a dedicated nominated lead that we liaise with directly, and we also work very closely with chief executives. So we, if we look at it by region, I can just very briefly summarise, if you wish. So in the North region, prior to the creation of the task force, there were no on-island services for adults for forensic medical examination. That's not the case any longer. There's a dedicated healthcare suite in the new hospital in Orkney. There's a dedicated suite in Shetland. Western Isles have also they were in a GP surgery and they've moved into a hospital setting. We provided some funding for that. NHS Grampian has dedicated healthcare facilities in the Health Village in Aberdeen, which was actually there before the task force was established. We've provided funding to NHS Tayside to move their suite out of a police station and into NHS premises. And Grampian, yeah, I think that's all, everyone in the north. In the southeast, there are dedicated new facilities in NHS Fife and NHS Forth Valley. They were previously located in a police station, and we provided funding to ensure that they were moved into an appropriate healthcare setting. In NHS Lothian, the suite is currently in the Ashley Ainsley in Edinburgh, and there's also another suite in the Civic Centre in Livingston, which is a multi-agency centre with a dedicated healthcare suite, and we've recently provided some funding to make some improvements there as well. And in Edinburgh, we're providing a significant amount of funding for a new regional centre of expertise, which will be hopefully opening around the summertime. The other board in the south east is NHS Borders. So they are progressing work for their local facility. Unfortunately, we just had word recently that they've had to pause that because they actually need the space to decant patients to create COVID-19 space. So that has had to take priority. In the west, NHS Greater Glasgow and Clyde have their service at Archway, which is a healthcare facility, and we've provided funding for a new regional centre of expertise in Glasgow, which will increase capacity as well, and it will be a multi-agency facility with more space so that, as I say, police can do their interviews, etc. as well. NHS Lanarkshire, I went to visit their new suite just a couple of weeks ago. That's due to open end of April, I believe. And NHS Ayrshire and Arran have also got a lovely new suite in Prestwick, which I went to visit recently in dedicated NHS facility. Similarly, NHS Dumfries and Galloway, they were in a police station and we provided funding to create a new suite in the Mountain Hall Treatment Centre. That's been open since last June and they have their locally trained staff there to provide that service. So by and large, I mean, I don't know the timescales for the experiences of people that you heard, but certainly there should be no examinations ever happening in a police station anymore.
Thank you very much. Thank you.
And finally, on the work of the task force, Tansy, can you tell us what the process of evaluation will be when the task force has completed its work?
Yes, so at the moment we are, as I say, we're working very closely with Health Board Chief Executives, and we get quarterly returns from each board with their performance against the HIS standards. And going forward, the package of resources that I mentioned in the opening statement will ensure that Health Board performance against the quality indicators is that data is collected and reported against, and that data, those reports will be published and publicly available. And we are also looking to establish a managed clinical network for these services. Those exist for children and young people services just now, but we want to create one that brings together the adult and the sexual abuse element of the child MCN as a kind of overarching body to oversee how services are developing and to kind of monitor performance against the indicators and where issues are identified that might need further improvement. And we're working with Healthcare Improvement Scotland to develop that quality assurance process to ensure that where there are issues that arise, they can be dealt with appropriately, and we envisage that this will be part of Health Board annual appraisal process, etc. as well.
Thank you very much. Alec O'Hampton.
Mina, good morning to the panel. We really appreciate you being here today. So the government considers that the best approach in the Child Rights and Welfare Impact Assessment, the government states that it considers that the best approach is to align the bill with the general age of legal capacity, 16, the age of consent, and you restrict self-referrals to those who are 16 and over. Yeah, obviously, rape is the antithesis of consent. There's no connection there. I just wonder why it was felt that 16 was appropriate, given that, in particular, if a child or a young person, say 13, 14-year-old, has the mental capacity to understand what self-referral is and is raped by a family member, that it might be very difficult for that person to find somebody to come with them to report that rape, given that they might be in quite a coercive family relationship to begin with. Can you explain your thinking there?
Thank you. Yeah, I'll pass to Greg to cover that from a bill perspective.
So I think another relevant factor to note is that age 16 is the current age applied at the existing self-referral services. So that's the Archway facility in Glasgow and the facility in Tayside. I'll ask Dr. Doyle to come in on the paediatric clinical element and the Children and Young People expert group and the work he's doing on the future children's pathway, but I think it would be right to recognise there's been a range of evidence submitted to the committee, and so some stakeholders have said, might the age be younger? And this is, of course, the minimum age for accessing self-referral. It's not a guarantee that anyone above that age will always be able to access self-referral. And I think with evidence from NSPCC and now Social Work Scotland, there are those saying, actually, is there a case for upping the age? So I think it will be interesting from the government's perspective to see the committee's assessment of that in due course. As you've mentioned, the Children's Rights and Welfare Impact Assessment is where we have set out in most detail the rationale for age 16. So key piece of legislation at the time following the 2019 consultation process seemed to be the Sexual Offences Scotland Act 2009, the Age of Legal Capacity Scotland Act 1991, as you've mentioned. It's also, I think, relevant that the Mental Health and Incapacity legislation, including Adult Support and Protection Act, defines adult as 16. That's, of course, all subject to a live review by John Scott QC. So we don't want to preempt that. But I think it's important to focus on Section 3 of the bill, which refers to professional judgment. I'm not sure that was fully understood by everyone reading the bill, but that's to recognise that there will be very difficult cases, and clinicians and paediatricians are well placed to work through these. And in many ways, the bill doesn't give rise to new issues because young people will be phoning Rape Crisis Scotland or accessing community pharmacy or going to GUM services in these difficult situations. So don't...
Ask a supplemental that I'm sure Dr. Doyle has a view on as well, because I understand all of that, and I'm not saying I have a problem with it. We're all quite new to this landscape, but I think a lot of the acts and sort of thresholds that you mentioned before are about rights and responsibilities and choices that children make. This is about a service that they can receive, and I just want to know, in the current setup and the future setup, if this goes through and remains at 16, what happens if a 15-year-old presents at the Archway? Are they turned away if they've just been raped?
No, I mean, everyone has the right to access healthcare under the NHS Act already. So I think we may have even said in the policy memo, no one's going to be turned away. I think the best practice for people who, for one reason or other, can't access self-referral is, rather than just disempowering them and saying, we're calling the police, whatever you think, that their situation is explained to them. We now have the Rape Crisis Advocacy Project. We have the Trauma-Informed Workforce, and that ideally the young person under the age cut-off or the vulnerable adult is put in a situation where they understand their position under child protection reporting guidance and so on, and they're empowered to make that decision themselves. But absolutely, and I'm sure Tansy will agree, you know, giving out people access to healthcare is the function of this bill. Another relevant factor I should have mentioned is a young person accessing forensic medical examination is actually really quite rare, because generally child sexual abuse is disclosed quite some time outside of the 7-day forensic window. So we tried in the bill to accommodate the situation where someone seeks forensics, but it's not relevant to them. So there's a section 4 about the healthcare needs focus, that's the absolute priority, even if no FME goes ahead. And again, section 3, the professional judgment, recognising that we're offering legal clarity and underpinning to the task force, to the health boards, but we don't want to over-legislate and be too inflexible. So, you know, as I say, new voices have come into this debate since the 2019 consultation closed. It will be interesting to see the committee's assessment. Would there be different options for the bill itself? You know, the age 16 could, in theory, be left to professional judgment, which is what we're saying for vulnerable adults, or a different age cutoff could be added. I thought it was interesting some of the written evidence was saying maybe keep it at 16 now and change in future, so that is a delegated power an option. As I say, very interested to see what the committee makes. I believe you have a panel of children's stakeholders coming up. Dr. Doyle.
Edward Doyle.
So there's absolutely no intention that anyone needing healthcare would be turned away. There was a strong view in the work we did.
Just to clarify my question there, I just think, because it is very important to get this right, I accept that, and I wouldn't expect that anyone who needed healthcare would be turned away, but somebody who wanted access to justice, who saw a crime had been committed against them, didn't really have anyone around them to support them to go to that, and didn't want to go straight to the police first. Is that I'm talking about, rather than healthcare?
The provision there would be for the professional seeing a young person to make an assessment of risk and vulnerability, and either with the young person's consent or potentially without it, to involve other agencies and to invoke the mechanism which we call an interagency referral discussion. And that's the key decision point in child protection procedures. And certainly at the minute, the legal situations child protection procedures apply to children and young people up to the age of 16. So a child or young person in that situation would not be, so they clearly would receive healthcare, but the input would not be limited to healthcare. There would be an assessment of risk and vulnerability. And if we widen that out a bit, that would always be the situation with other forms of abuse, physical abuse as well as sexual abuse, emotional abuse, neglect. And for many of the professionals who we're talking about here, this is core business. The concepts, the detail would be restricted in this case to child sexual abuse, but the concepts are very well understood. They're widely practiced, and the responsibilities, as well as being part of the legal framework in Scotland, are embedded in professional responsibilities with the regulatory bodies.
Much. And the principles of the Barnahus, that's something, the Icelandic model that I think you've sought to reflect. How are they reflected in the bill?
So certainly the aim is that the bill should be Barnahus ready, but Barnahus is about so much more than forensic medical examination and sexual abuse. And I think the SPICE report acknowledges that when you look at the Barnahus model, it doesn't actually have to have FME on premises. There are some international Barnahus models where that's in a separate hospital. So it remains to be seen where Scotland's going there. So I can't remember off the top of my head, but I think there was definitely one stakeholder, possibly Children's Reporters Administration, that sees this bill as a step forward towards Barnahus. I think perhaps other stakeholders were unsure, but the intention has been, this isn't a Barnahus bill, but we want it to be Barnahus ready. And that's very much in the spirit that my colleague mentioned of, although this bill legislates for health boards to deliver the legal clarity and underpinning that the Inspectorate of Constabulary was looking for, it is intended to work in a multi-agency context, in the context that police and social care have their due role, third sector has their role, and all of this comes together under the National Performance Framework. That's the glue that binds it all together.
Thank you very much. Tansy Main.
Just to add to what Greg said, the service specification document that I mentioned makes reference to the fact that services should be designed in to ensure an age-appropriate environment. So where there are facilities that are seeing both adults, children and young people. We've been very clear that they need to be designed with the principles of Barna House in mind, and effectively that's about creating a child-centred environment and ensuring that it's appropriate for that age group. So some health boards are having all their FME for all ages in the one facility where they've got the space to do that. In others, the child examinations will happen within a paediatric unit as is existing practice, but absolutely the design of services has been done with that Barna House in mind.
Thank you very much. Emma Harper.
Thank you, Convener. Good morning, everybody. I'm interested in some of the issues around the sex of the examiner, and Tansy, you talked about the need for developing more female forensic medical examiners. In the Spice briefing, it talks about the policy memorandum has a proposal for nurse sexual offence examiner project, so not just GPs doing the examination. And when I visited the Mountain Hall Centre at Dumfries last Friday, Wendy Copeland is doing a fantastic job and told me a lot about what the plan is, and they're hoping to have a women-led service ultimately. But it would be interesting to hear a wee bit more about how are we, what's the proposals for widening access to have more women examiners?
Certainly. Is that specifically in relation to nurses or doctors as well? Or
Doctors as well, because
okay.
I know that, that there's, you know, the chaperones being female. I heard last week that even men who are raped and assaulted are choosing female examiners as well. So I think that that's something that people might not necessarily be aware of.
Yeah. I touched in the opening statement on the work we've been doing around increasing the number of female doctors, and as I say, the statistics that we have indicate a 30% increase from when the HMICS report was published, but that's still not 100%. And we recognise there's still a long way to go, and we're working very hard with health boards to try and continuously improve that. But certainly the NES training and the other things that we've been looking at around the remote evidence to court, for example, is one of the things that we've had feedback from female examiners, particularly who might be GPs who maybe work in the north of Scotland, who are called to the High Court to give evidence in a trial, who might have childcare responsibilities in a clinic to run, that can almost disincentivise them from being involved in this kind of work. So that's why we were looking at the remote evidence to try and retain the female doctors that we have as well. But the real key to ensuring that people who want a female examiner can have one is the nurse examiner model, and that is something that has been is not new. It's the concept of sexual offence nurse examiners has been in England for almost 20 years, and they regularly undertake examinations and give evidence in court if required to do so. We've done a lot of work since the HMICS report to develop detailed proposals for how we would adopt that model in Scotland. So we have that approval from ministers and the Lord Advocate to undertake a test of change. We're actually this month recruiting for 2 nurse examiners to do that work. So they will be, in order to qualify as a nurse examiner, at the moment in England, nurses have to undertake a postgraduate qualification for a year. In advanced forensic practice, and then they have to do a certain period of kind of on the job kind of shadowing before they're able to fly solo, as it were. So the nurses that we will be recruiting to this test of change will have the level of qualifications and experience and knowledge that is required to do this role. There are only a couple of nurses in Scotland at the moment who already have that qualification, because it's Staffordshire University in England that offers that course at the moment. So in parallel to the test of change, which I'll come back to in a moment, we're also working with Queen Margaret University to create a new postgraduate qualification in Scotland so that the workforce here can access that training, and that's due to start in September this year. And the government are providing funding for 10 places on that training course, with priority will be given to particularly boards in rural and island areas where we know having female examiners is particularly challenging. the test of change, we're hoping will start around June, and that'll be hosted in the Archway Service in Greater Glasgow and Clyde. We've worked very, very closely with the Crown Office and Police Scotland around that to ensure that they have the safeguards and reassurances in place that they would require to ensure that there is no risk to the criminal justice process. And we're also working with Rape Crisis, actually, who are going to be involved in the evaluation of that and getting feedback from survivors about the impact of nurse examiners. So we very much see this model as key to creating a multidisciplinary workforce. I don't think will ever be in a case of it's only nurses or it's only doctors, but being able to increase the pool of people available, and a majority of the nurses who are interested in this work are female, understandably. So there is a lot of appetite from health boards already. They're very keen to send nurses on this training, and hopefully when the test of change concludes, we'll have the first couple of cohorts will have come through the Queen Margaret University postgraduate qualification, and will be ready to commence that work. So we're hopeful that that will be the kind of landscape for the future.
Okay, thanks.
Sandra White.
Can I ask a supplementary to the previous question, if you don't mind, in regards to the numbers of female doctors and nurses? In your opening statement, Tansy, you mentioned the fact that 118 doctors, 70% which were female, and nurses, 68 nurses, and that up 90% of females in that respect. And then obviously in your answers to my colleague Emma Harper, you mentioned about 2 forensic practice nurses. How many exactly do we have female doctors and nurses that are capable of doing this type of forensic examination throughout Scotland?
So the
I mean, you can send it to us if you don't
Yes,
have
sorry.
it at hand.
I do have that. Sorry, bear with me a wee second. I do have that somewhere. Yeah, I can. Can I come back to that?
Yeah,
Sorry,
sure you
yeah.
can.
If you want to ask
Sorry,
your other questions, and then
yeah.
Tansy can come back to that.
Yeah.
That's fine.
I do have
Just
it here.
another
Hold
sup
on.
for that one, because I think it's really important we
here
get
we
to
are.
know how many there are.
Sorry, I've got it now. Sorry. The stats show there are 70 sexual offence examiners in Scotland at the moment, of which 43 are female, which is 61%.
Okay, that's. I just wanted to get the numbers, because obviously we're talking about training as well, and
Yeah.
I know I might be labouring this point. Sorry, but basically, obviously, you said Stafford University, and then we're going to open up a course at Queen Margaret University. So there's been no courses in forensic examination of this type in Scotland. That's what I couldn't quite get my head round.
So the NHS Education Scotland training that all doctors and nurses who are currently delivering this service are required to attend, that's run, as I say, that's run by NES. So the doctors, by virtue of having a medical qualification, undertake a shorter training in order to be able to do this work. And the nurses who attend the examinations to assist the doctor and to provide that trauma-informed support to the survivor is also able to go to that training. So they understand the process, they can explain it to
It's
someone.
available in Scotland, though.
Yes, so the NES training happens in Scotland,
That's fine. I just wanted
and
to
it's
know
actually been adapted so that it's more portable, so it can be delivered in more remote and rural locations. The Queen Margaret training is specifically for sexual offence nurse examiners, and it's that qualification that is a year-long training that isn't currently available in Scotland, but will be in
That's the
future.
point I wanted to, because obviously if we are pushing for this, and obviously people, it's a very important point.
Yeah.
It wasn't available here in Scotland previously then.
Nurse examiners training, no.
No,
but it
that's
will
fine.
be,
I just
yeah.
wanted to pinpoint that particular point. If I could just ask another question that I was going to ask, and you touched on it, I think, earlier on as well. It's about the healthcare needs, and we certainly heard lots of information from the witnesses at private session in regards to psychological needs, the trauma people go through, even 10 years later. If they're going for a particular examination, it brings it all back, and they haven't had any support whatsoever. And you did mention a lot about healthcare needs and healthcare terminology in that respect. So I just wanted to ask you two perhaps maybe quick questions. I don't know, it depends how people want to answer them. Really, basically, for myself and others, what does the term healthcare needs really mean? Is it, will there be guidance given, you know, basically what healthcare needs actually is? And one of the most important things, I think, is would it be anticipated along with this umbrella of healthcare needs? Will it include mental health needs and psychological support? I think that was two of the biggest ones. So I'll just leave it at that for you, whoever wants to answer.
I'll just give a brief answer, and then I'll maybe pass to Dr Doyle, who chairs the Clinical Pathways subgroup for the task force. But certainly the clinical pathways that has been developed is very much around that holistic healthcare response. So as well as the forensic medical examination, which we hear from feedback from survivors can be the most traumatic for people, is actually a small part of their the service that should be provided to them, and it's actually that wraparound care and assessment of their psychological and emotional health and well-being, their safeguarding and their needs, and what referrals they may need to other services such as mental health or rape crisis, etc. And in terms of the task force, one of the things that the Chief Medical Officer also asked of Chief Executives was to ensure that they have a nurse coordinator in place. So that may be the same person, the same nurse that attends the examination. In some boards, it's a different role, and in some places that's embedded within the gender-based violence service or the sexual health service. But that person's role is really to ensure that after the forensic medical examination, the person isn't left to navigate their own way around the health system, and that they are supported to access the ongoing care and support that they need. And as I say, some health boards already have that in post, and others are working towards that, and that will make a big difference to ensuring that people have that single point of contact to support them as they progress through their recovery journey. Eddie?
We use healthcare needs as a very broad umbrella, and if you think of this situation, it might start with managing an acute injury, control of hemorrhage or something, and then we think usually in terms of the actual forensic examination. But one of the things we've tried to do with the clinical pathway is to give practitioners a structure to work through there. So as well as acute injuries, forensic examination, they're prompted to think about things like emergency contraception, vaccination for hepatitis B or something, HIV prophylaxis, and there's guidance in the pathway about that. We'd move on to thinking about whether this person should be referred to sexual health services. Then you might think about, in the medium term, drug and alcohol services, but we're also very mindful of the need for ongoing mental health support in its widest sense. Now, that might not be psychiatry, it might be psychology or counselling. And we've done quite a lot of work on how that would look for people past the acute episode, including for children and young people. And there's some test of change that we're working on in the West to inform further developments on that. And there's been an awful lot of work gone into this by the Children and Young People's Expert Group on how we provide consistent, high-quality therapeutic support for young victims across the piece in Scotland. So we're very mindful of that, and all that is under the umbrella of healthcare needs.
I think earlier, Convener, I referred to the healthcare needs section as section 4. It's actually section 5. And I can't really add to what Dr Doyle said in terms of what that's intended to mean. Just to pick up some related points on the bill, the way we have drafted the bill generally, and specifically the definition of forensic medical examination, is you can't really ever entirely disentangle in the FME process the healthcare needs and the clinical things and the forensics justice things. So we haven't really attempted to. We've tried to find the best interface between wider law and practice and this bill. Another point I think I can usefully pick up that's coming to a few of the exchanges so far is the trauma-informed principle. So in the schedule of the bill on page 9, we are proposing to add to statute book for the first time the principle of trauma-informed care. And that's certainly been welcomed by NHS Education Scotland NES, because they feel that very much complements all the good work they've been doing in guidance and training.
Tansy Main.
Just very briefly, just to add that the final his quality indicators have been published. Indicator 4 is around assessing support needs and ongoing safety planning, and Indicator 5 is around access to immediate sexual health care. So those are measures that previously weren't kind of available, and therefore that risked people perhaps slipping through the net and being discharged from the FME service without that ongoing safety planning and support in place. So the quality indicators will help to focus health boards' minds on the importance of ensuring that that is all provided in a holistic manner.
Could I? Sorry, just very briefly. Thank you so much for your evidence, and very interested in Mr Walker's evidence about the trauma-informed workforce. But then, Tansy, you mentioned at the end to advise. Now, Greg Walker said that that would be in legislation about the trauma-enforced workforce. So I would really be keen, and it would be up to the committee, that when we hear from others, that we can actually put, you know, either amendments or whatever into, you know, whatever's in the bill, because I think it's really important. We've talked a lot about clinical, forensic, etc., but it's about the victims, and I think that's a really important part about the trauma. So thanks so much for that, and I'll go and look at section 5 and see what I can see, and I think it's page 9 you mentioned as well.
Yes,
Yeah.
if it's at all helpful, the precise legislative references, the schedule, part 2, paragraph 3, 5,
I'll pick
B.
it up from the audio.
The clerks will perhaps help with that, but it's on page 9.
Thank you so much, that's great, thank you.
Brian Whittle.
Thank you, Convener. Good morning to the panel. Can I ask why it was decided that timescales for attention would not be specified within the bill, but would be set out by Scottish ministers in regulation rather than included in the face of the bill?
So, when we launched the 2019 consultation, which was entitled Equally Safe, a consultation on legislation to improve forensic medical services for victims of rape and sexual assault, we perhaps realised that people would express views about self-referral on a general basis, but maybe not get into the details of, well, which body holds the samples for how long, what are victims' rights. So we had a very useful workshop involving Rape Crisis Scotland, Health Boards, Police Scotland and others about a year ago. And I think quite easily we got to a consensus that the health boards had to hold the samples for that retention period. I think what came out very strongly is, given that in the advent of a rape and sexual assault, a victim's autonomy and consent has been taken away completely. We need to give real rights to victims, which is why you see the bill providing for a right to instruct destruction of samples, a right to instruct transfer to the police, a duty to make sure that victims are informed at the time of examination of what the retention period would be, have that explained to them. Frankly, we didn't get to a consensus on the retention period, and Tansy mentioned there's now a new self-referral subgroup. And looking at practice around the UK, there is no consistency in any part of the UK other than Northern Ireland. Why does it have a single retention period? Because it has one facility that covers the whole province. So there is a recommendation from the Faculty of Forensic and Legal Medicine that says 2 years. But occasionally it's put to us that any retention period that's on an anniversary could be triggering and traumatising. So that's very much a live question for the self-referral subgroup. If during the course of parliamentary proceedings the committee has a view or there appears to be a consensus, it could be amended into the bill. But I think another relevant factor why it's in regulations is that the services around the UK have actually changed their period, and that FFLM and other guidance could change. So allowing it to be prescribed by regulations, and we're proposing affirmative so there be due scrutiny by committee in the chamber, it allows for things to evolve with medical and forensic science, and also survivor input will be really important before that's prescribed.
Tansy Main.
Thank you, Convener. Just to add to that, so the self-referral subgroup under the task force are at the moment trying to gather best practice from elsewhere in the UK, looking primarily at the SARCs in England that are very well established. And as Greg says, there is no real consistency, although the evidence that we've gathered so far, most places are around 2 years, some places it's 1 year. But what has been really interesting that we've heard from SARCs is that the majority of survivors who self-refer actually decide to report to the police fairly soon after the event, almost the majority kind of within a month or a couple of months. And that's why one of the services in London has actually reduced their retention period to a year, because they found that the majority of people decide fairly quickly to report. So we'll look at all of that evidence and share that with ministers and with the committee to help inform that debate.
Good. Just to confirm that, I think you mentioned you'll be looking to seek the views and input from victims themselves on the length of time that the wish samples retained. Is that correct?
Yes, I mean, for any affirmative instrument, the committee would be asking us, what consultation have you done? And so we're thinking about that quite actively at the moment.
And just to add to that, Sandy Brindley is Chief Executive of Rape Crisis Scotland, is a key member of the self-referral subgroup, and the task force will ensure that the voices of survivors is heard in all of our deliberations. And Sandy also chairs one of the groups that sit underneath that subgroup that's looking at how survivors will access services. So we very much are seeking to ensure that the survivors' voices are front and centre of those deliberations.
Supplementary from Emma Harbour.
Thank you. Just the issue of 2 years for evidence. We're talking about like DNA, physical evidence, that kind of evidence, because other evidence can be retained, like photographic evidence, that would last forever, really. So is that 2 year period specifically related to physical evidence, like DNA type?
I should clarify that that's not government policy. I'm just simply pointing out what is in the UK Faculty of Forensic and Legal Medicine guidance at the moment. It's not fully adhered to across the UK. The bill contemplates that victims have control of all types of evidence provided by them. And so whether that's samples, any clothing, any colposcope images, you know, if they instruct deletion, they're gone. If they instruct transfer to the police, they're seized by the police and become a criminal production. But the bill's recognising that, as well as the question of the retention, the period, the question of what is retained is also something that's open to clinical judgment, open to what the victim consents to, what they think is best for them. And again, the self-referral subgroup is thinking very actively about this.
Okay, thank you very much. David Stewart.
Thank you, Convener. Last week, as the panel will know, we met 10 women survivors, and one of the key issues that came out was the lack of support and the need for independent advocacy. Was there any consideration given to that concept when the development of the bill?
Certainly, in the policy memorandum, we reference the Rape Crisis Advocacy Project, and perhaps you can, you know, hear from Sandy Brindley later about how that feels for Rape Crisis Scotland's purposes. But you know, we don't want to over-legislate and say that that other bodies will do this and that, because that's something that exists. I think it's working quite well, and it could have a particularly important role to play for self-referral, because that will be a new proposition for most parts of Scotland, and possibly something that's not in many victims' minds at the moment. Don't know if Tansy has anything to add on that.
Not a great deal. Just you know, the funding for the National Advocacy Project for Rape Crisis Scotland comes through our Equality and Violence Against Women and Girls colleagues, and the government are very committed to that project and ensuring that people are able to access those advocacy services.
But so you convener, but certainly I understand the issue about over-legislating, but clearly just looking at the very harrowing meeting that we had last week, I think we were all struck with how absolutely nightmarishly horrible it was, experience that the women had. I'm sure that's replicated throughout Scotland for other victims. Clearly there's a demand for having advocacy services like my own and rape and sexual abuse services in Highland within my own region. I'm not convinced I would use the word over-legislating. I think there is a huge gap here, and these services are absolutely vital. Is there anything to be done at this late stage to change that?
That is ultimately a matter for the committee. In terms of what the bill does to dovetail with advocacy services, the section 4 is essentially a victims' rights section saying that ahead of the examination, you know, people must be given information and understand that one of the things you heard last week was it wasn't clear to victims what was going on, why things were being taken, what would happen next. And in section 4.2b, it says that information must be explained, so that can be by the health board's trauma-informed workforce working in partnership with others. I think another relevant factor is because we're applying the Patients' Rights Act to everything under this new bill, that talks about accessibility of information. And in that spirit, we published an easy-read summary for the bill because that had been called for bodies like People First Scotland. So I think there's a lot of good work already going on, and I appreciate you heard some pretty terrible things, but as my colleague was saying, you know, we are beginning to turn a corner and people are beginning to have better experiences where they have positive support from advocates, they have good experience of the examiner and the forensic trained nurse, and it doesn't feel like a police process anymore. It feels like their healthcare and recovery is front and centre.
On that point, then, Convener, I mean, will the police be encouraged to tell people about the option of self-referral services?
Tansy?
Yes, so the access to services and a subgroup of the self-referral group that Sandy chairs is looking at how survivors will access services and what information will be available, and Police Scotland and the SP and other key partners are part of that work, and will ensure that you know, Police Scotland information materials can point people to the fact that you don't need to speak to us first, there are other options available to you.
And my final point in this section, Convener, did the government look at all at best practice in other parts of the United Kingdom? For example, the England, Wales and Northern Ireland Victims Commissioner project. I have to declare a certain interest as I proposed a bill on that very same subject some years ago. Obviously, as members of the panel will know, the issue there is about who stands up for victims, something certainly I took a lot of evidence on this a number of years ago and met the Victims Commissioner in London and telephoned the Northern Ireland Victims Commissioner. That wasn't a model the government chose to go down the road for, and I accept that the legislation isn't specifically about this, but clearly there's a huge issue about who's standing up for victims. So independent advocacy is one argument, sharing victims' experience so we can get the law better is another argument. Have you looked at any of the themes of victims commissioners in other nations in the UK and brought that into the legislation that we're now talking about?
To pick up a few of those points, on rest of UK services, absolutely, because self-referral is well established in other parts of the UK. So there have been a number of facility visits, and I should record that colleagues around the UK have been extremely generous of their time and expertise. You know, indeed, they produced in so much data as they could to help us inform the modelling assumptions in the financial memorandum. We were planning additional visits, which are obviously on hold for the time being. On the particular point about victims policy, this is a healthcare bill, but it's also a justice and a victims bill. So the task force you've heard about is complementary to the victims task force, which is underway, and that has important survivor liaison. I believe Sandy Brindley's involved in that task force as well. The work is well coordinated within government. And I understand the questions of a victims commissioner is within the remit of that task force to consider. But I would suggest that's a wider justice system measure, not specific to this bill. But, you know, we include the word victims in the title of this bill deliberately. It is a victims bill.
As you would probably expect to say, I mean, with joined-up government, I would hope we're not in silos. We could see that victims and the front line that we're currently experiencing in the horrors of rape and sexual assault. Clearly, the needs of victims must be highlighted in this legislation.
If I could just come in, the committee might find it helpful to note that the bill also amends the Victims and Witnesses Scotland Act 2014. And there's a section in that particular act that allows referral to providers of victim support services. So that particular provision will also apply to people accessing services under the bill.
I think that's very positive. It's also essential not that the services are there and are developed, but the people know about them. And clearly that was something we were picking up from the harrowing evidence we took last week. Could I just move on to another area? I don't think we've covered this yet, Convener, but do stop me if we have. And that's the issue around capacity and consent to be examined. You know, what guidance will be issued to health boards in relation to legal capacity and consent, particularly in relation to self-referral?
To return to something Dr. Doyle and I had said earlier, the bill in a sense doesn't give rise to new issues because there are existing FME services across Scotland. There are some self-referral services. There is extensive guidance from General Medical Council, Royal College of Nurses. There are also Scottish pieces of guidance like adult support and protection guidance, of the current and future child protection guidance. On that point, I keep coming back to about providing sufficient legal basis and clarity, but guarding against the risks of over-legislating. We felt that because principles of consent and informed consent are so well embedded in general Scots law and clinical practice that we didn't need to replicate them in the bill, but certainly the policy is that absolutely everything should be done on the basis of informed consent with as much survivor input and control as possible. The adult clinical pathway that Tansy mentioned, what comes out very strongly on that is the principle of supported decision-making from the UN Convention on the Rights of Persons with a Disability. So that's particularly thinking about perhaps adults with a learning disability, but generally the idea that people should be empowered to make as many decisions as possible themselves and know what's going on. I don't know if Dr. Doyle has anything to add about clinical practice.
I do anything to add, I think, at this stage, I think, is that all health boards have revised their approach to consent in the wider sense in the light of a significant medical legal ruling in 2015, which was called Montgomery against NHS Lanarkshire. So there's been an awful lot of work on that, and you know, the process we're talking about today will have been captured in that thinking as well.
You've covered this finally then, Convener. So basically, do we need to have any change to examinations and any improvements to ensure people are able to give true informed consent?
I think we would say that's the current best practice, and that is what is being delivered on the ground today.
Okay, right. Thank you, Convener.
Thank you very much. Just before we move on, Greg Walker, you said you referred to the issue of the witness or the victim of a sexual offence having control of the evidence and around the issues that Brian Whittle raised on retention. Would I take, was the implication of what you said that once evidence was passed to the police, then the victim was no longer in control of that evidence?
Firstly, to say the bill legislates for health board responsibilities. It legislates for the interfaces in police referral cases where a constable brings a victim to a facility. That is the usual model in Scotland today. There's a sexual offence liaison officer that handles that. So police processes have improved a lot. The bill also picks up for the point that the constable takes the evidence away. The wider justice process is legislated for separately. So most recently, the Parliament's passed the Scottish Biometrics Commissioner Bill, so that's part of the mix of the law that applies on the criminal justice end. As my colleague Katie Richards says, we recognise the important role of the Victims and Witnesses Act, so that act is partially applied to this bill where relevant. The Patients' Rights Act, we would suggest, is the most relevant rights act for a healthcare bill, and it's fully applied, including now the trauma-informed wording. But the Victims and Witnesses Act, the Victims Code for Scotland under it, that fully applies to victims after they make a police report, things like the appropriate adult service. So there's a number of measures and reforms that are in place for victims once they're in the justice system. However, this bill has to accommodate the possibility a victim chooses never to go there.
And just so that I understand, in practical terms, what does that mean in terms of the victim's control of evidence once the police have taken it away?
So to come to some of the feedback we've had from survivors, in a police investigation, it may be that more evidence is taken, maybe scarves and jewellery and things like that. So under the Victims and Witnesses Act, they can request that back. That process should be smooth under guidance. The suggestion was a few years ago it wasn't as smooth as it should be, but I'm certain that's the sort of thing the Victims Task Force will be looking at.
Okay, thank you very much. Emma Harper.
Thank you. Some of the issues that were raised by respondents had concerns of the increased cost to health boards with implementing provisions in the bill. But it sounds like already the Scottish Government has provided funding to health boards to set up the sexual assault centres in healthcare facilities. So I'm just wondering, what are the concerns that have been raised by health boards regarding long-term funding, and then, you know, what action then has been taken by the Scottish Government to support the future long-term funding?
Thank you. So, as I mentioned earlier, we've committed, Scottish Government has committed £8.5 million over 3 years to support health boards to embed the Healthcare Improvement Scotland standards and to prepare for the forthcoming legislation. And this has been pump prime funding, really to build the capacity of the workforce, as you said, to improve the physical environment, procure the essential equipment, and to deliver national projects as well, such as an IT system. Everyone was at different starting points. Some health boards were already delivering services, others weren't or had significant improvements to make. So our aim was to bring everybody up to a similar standard. And so in order to do that, we asked each health board to do a self-assessment against the HIS standards. And that then informed a gap analysis. And from there, they could identify what funding they would require in order to help them to meet the HIS standards. So those costed local plans from each health board came into the task force and bid for funding, and that was to ensure that the funding was targeted where it was needed most. So we're actually just in the process at the moment of reviewing what their funding needs are for this coming financial year. But all of the health board funding that has been provided to health boards has been done so on the basis that the health boards have committed to sustaining those services that are developed using the task force funding beyond the lifetime of the ring-fenced task force allocation. So a significant amount of the funding has gone into capital developments, premises and equipment, etc. But we have also provided funding, as I say, to pump prime recruitment of staff, of forensically trained nurses to be present during examinations, etc., to increase the number of female doctors in the archery service, for instance. And so we're very much on an improvement journey there. And there, in terms of the workforce, there will be a revenue tail come the end of the task force funding. And we are working with health boards to look at what that fully costed model would look like beyond 21-22. But as I say, health boards have committed to maintaining the services that are developed utilising that task force funding.
Are health boards concerned that they're going to see like a big increase in numbers of persons coming forward? Are they worried about that might be impacting where we are? I mean, because we want people to come forward and feel safe and secure and have a holistic approach to, you know, any rape or sexual assault needs to be dealt with in a trauma-informed way. Are health boards worried that they're going to see a real rise in numbers?
I think, to be fair, there is some concern around that. The modelling in the financial memorandum was based on the best available information that we had at the time, and that indicates around a 10% increase expected demand for self-referrals. So bearing in mind that the police referral model is already exists, so the increase in demand on health boards will primarily arise from those choosing to access a self-referral instead of a police referral. So that 10% spread between the 14 boards, understandably, you know, the larger boards will have a greater proportionate share of that demand. I think the financial memorandum indicates, I think it's in between £220,000 to £290,000 per year across all 14 boards. So the cost per board is not significant in the grand scheme of their health board funding from the government. But I think time will tell what the level of demand looks like. We know that sexual crime is often underreported, and it may be that as awareness grows of the availability of this service, that demand will gradually increase over time, but we expect that to be incremental rather than a sort of a big surge at the beginning. Certainly from when the bill is implemented, we expect that the cost of the increased demand for self-referral to be not too great on a per board basis.
I think, I mean, we will see, obviously, as people find out about a self-referral process, that obviously will mean that they'll get to the right place and the right people. So and you'll be tracking all the, I guess, the data, whether it's rural areas versus more urban, and you said that there might be different numbers as well. So is there any additional, I guess, concern where in the modelling it says for medium demand there is a projected 20% increase from low demand scenario, but in the high demand it says here 35%. Is that just part of the modelling that has been done to look at how numbers will be projected?
Yes, as I say, it's been very difficult because we haven't had a consistent means of gathering data on existing demand for services at the moment. So we have done a kind of trawl from health boards, and we've asked them to provide some figures for the task force, and we understand that in the last calendar year there were 697 police referral examinations that required a forensic medical examination, and 46 self-referral. So at the moment, the number of self-referrals is very low in comparison to the number of police referrals. As I say, we now have that sort of baseline, and we'll be able to closely monitor how that demand increases over time.
Okay, thanks.
Thank you very much. David Torrance.
I've got a couple of questions around monitoring and evaluation. What consideration was given to including a provision in the bill to require monitoring and reporting by health boards?
So I imagine you're aware the Law Society has raised that very point. The package of resources that Tansy mentioned in the opening statement would include consistent national data collection so as to allow for modelling assumptions being replaced with real data, which will make it much easier to plan volumes moving forward. Again, on that point of what does the bill need and not need to cover, there's always an assessment made, and there is so much good stuff in the task force's work that where we felt that was adequately covered by this package of resources, the national form, the quality assurance arrangements, and how that is collated and reported back. We didn't feel that needed to be statutory, but I imagine the committee will take its own view on that.
Can I ask, around data collection on forensic medical examinations, how will that be driven to improve improvements in the service?
As I noted in the opening statement, so the package of resources includes a national form to ensure that information has been recorded consistently, and each health board will provide data to Information Services Division of their which will demonstrate their performance against his quality indicators, and as I noted earlier, that information will be used as part of a quality assurance process that we're developing with Healthcare Improvement Scotland to ensure that the continuous improvement of services is always being looked at through, for example, the Health Board annual appraisal process and the adult the managed clinical network that I mentioned earlier as well.
Thank you.
Thank you very much. Brian Whittle.
Yeah, I want to look at the areas that are not included in the bill, and I think you'll know under the current memorandum of understanding between Police Scotland and the Health Board, although it covers more than forensic medical services for victims of sexual assault and rape, the Police Scotland pointed out in the wider provision remains outside of the legal framework of the bill. And specifically, the NSPC in their submission, they highlighted that the examination of children and young people who are alleged to be involved in sexual assault and abuse is not included in the bill. although they found that many children suspected of perpetrating sexual offences are subject to a forensic examination in police custody. And they wanted to say that they would support the provision in the bill being extended to cover the forensic examination of all children on a statutory basis for the provision of therapeutic interventions. So can I ask you, how will the provisions in the Memorandum of Understanding that are not included in the bill be continued, and will the Memorandum of Understanding be revised in light of this legislation?
There's a few points on that, so I'll give what answer I can, and I'll pass on to Dr. Doyle on the paediatric practice element. Forensic services is a really wide concept. There's very little legislation in Scotland about forensics. Even narrowing it down to forensic medical services, you're looking at a very wide concept, including toxicology, dentistry, all sorts of things. So in the 2019 consultation, we were looking, is there a consensus that there should be legislation at all to deliver the legal clarity HMICS was looking for? And also scope. So 91% of consultation responses endorsed the consultation proposals, which were focused on addressing the HMICS report, addressing the sorts of issues you've heard about from survivors. And so I suppose an assessment is made that we can make relatively quick progress on specific legislation in the context that the MOU remains in place for everything else. I think it's fair to put on record that the point NSPCC and Children First are making now, they also made last year, so we recognise they did make that point. We would take the view that if someone is accessing FME under this bill or under the MOU, there won't be a second tier service, because indeed you could have a situation where it's an FME under both bases. The trauma-informed workforce is there, the Patient Rights Act is there, and so on. So essentially, FME for children is rare generally because of the nature of when things are reported. In those rare instances where FME is needed for non-sexual child abuse, the basis would be the MOU, but I'll ask Dr. Doyle to explain how the practice is essentially the same.
In terms of joint paediatric forensic examinations, there's very little difference in practical terms between one for suspected sexual abuse and one for other forms of abuse or neglect. It tends to be the same people in the same facility. This bill hasn't been created in a vacuum. There have been standards and guidance around joint paediatric forensic examinations for a long time, training about that, and we've had the 3 managed clinical networks for child protection in Scotland for some years now, which have set standards, gather data, report through their own governance structures. So we don't feel that the fact that non-sexual abuse is not legislated in the bill will be detrimental to the service to children and young people for other forms of abuse.
And if I may come back to the Barnahus point, the Barnahus concept would encompass all forms of child abuse. The bill wouldn't be limiting it to FMEs for sex crimes only.
Okay, just a clarification there. I just wanted to clarify whether you had any consideration had been given to including children who have alleged to have perpetrated sexual abuse within the forensic medical examination bill, or do they sit outside of it?
So there is a recommendation in the HMICS report about child suspects, which was directed to Police Scotland and health boards, and that's currently being considered through a police care network. So we didn't see that as one to address in this bill. However, I understand that the New Age of Criminal Responsibility Scotland Act would, in the case of alleged perpetrators under 12, that would be the legal basis for them providing samples.
Okay.
Just to quickly add on that point, the Police Care Network have been looking to develop some specific standards for examinations of children or young people under the age of 12 who are suspected of a sexual crime. And the HMICS recommendation was that that doesn't happen in a police setting because they are still a child, even if they have been suspected of a crime. So the draft standards that they are considering will look in principle at ensuring that there's always an IRD takes place to determine the most appropriate place for that examination to happen, and that where at all possible for that to happen in a healthcare facility. And there would obviously need to be protocols in place between the health board and the police to ensure that the suspect isn't in the same location as the victim, at the same time. So they would very much have to be done separately. But the principle of being in a healthcare environment rather than a justice environment for a child that requires to have an examination is very much at the centre of that.
You referred to an IRD. Could you spell that out for
Oh,
the
sorry, it was mentioned earlier. Inter-agency referral discussion.
Thank you very much. Finally, both serious sexual assault and severe forms of childhood sexual abuse are sometimes associated with social economic disadvantage in particular. And so can you say whether the bill has been designed, or the work of the workforce is designed in a way that will make it easier for people who are victims in those circumstances, who are living in the poorest areas, to come forward and seek support?
Answer, and then you can come in. Certainly, we did a number of impact assessments, which we published together with the bill, and one of them was a Fairer Scotland duty assessment, a full assessment that you can read. We recognise there are social economic dynamics, there are other equalities dynamics, and where we have ended up is the bill talks about people, which is modern drafting practice. You'll see that in the clinical pathway as well. So everyone is entitled to the same service, but how the boards offer that in a position of equity is something that they would be thinking about through implementation coordinated by the task force. And so these impact assessments are not just being done for the bill, they're also being done for the package of supporting documentation that Tansy mentioned.
Just to add briefly to that, the task force undertook an options appraisal in 2018 to look at the model and configuration of services for Scotland. That was a rigorous process involving all of our key stakeholders, and very much the preferred model was for services to be delivered as close as possible to the point of need, which is why we have been developing local services in each of the 14 territorial health boards. Some boards have more than one local service, and that support from the regional centre. So in terms of being able to access the service, we recognise that it's important that people don't have too far to travel, which is why we were very much focused on that local service as far as possible.
Okay, thank you very much. And can I thank the bill team and all our witnesses this morning for the evidence you've given. We will, I'm sure, be talking to you again on some of these matters. And if there are points of information arising from any of the questions that you've answered this morning that you feel would be helpful to provide us with further information, then please feel free to supply that to us. We will now suspend for a few minutes in order to allow the round table, which is our next evidence session, to be set up. Thank you very much. A big spread out table. Thank you very much. And I resume the meeting and welcome back. We will take our next evidence session on the, as part of our scrutiny of the Forensic Medical Services Victims of Sexual Offences Scotland Bill at stage 1 and move to our round table session. I'm delighted we've been joined today by Sandy Brinley, Chief Executive of Rape Crisis Scotland, by Anne Robertson-Brown, the Vice Chair of Angus Violence Against Women Partnership, by Gwen Harrison, Manager of Rape and Sexual Abuse Service Highland, and by Jen Stewart, Centre Manager for Rape and Sexual Abuse Centre Perth and Kinross. Thank you all very much for taking part. Our round table session, it will involve members of the committee asking your views and looking for your opinions and your experience. But it is a bit more informal than the session you may just have watched with government witnesses. So feel free to ask questions back if you think that's going to help the dialogue and to refer. And don't feel that you have to answer every question and simply come in where you think there's something that you might want to add to the conversation. So we are spread out a little, but that's appropriate in the current circumstances. Can I start by asking a question for any of the witnesses who would like to come in, which is around some of the discussion we've already heard both today and informally in our very powerful and moving evidence session that we had informally last week. And ask what it is from the point of view of yourselves and the people with whom you deal. What are the aspects of the examination service which are most important for those who have been the victims of rape and sexual abuse?
I don't mind starting, and then maybe Gwen and Jen can come in here, but from the feedback that we have from survivors, that the key issues really are about access to a female doctor is the most important issue that is brought up by complainers speaking with us in terms of what causes the most trauma is lack of access to a female doctor. But another significant issue that came up at the closed session we had with survivors last week was delays. But you cannot overestimate the amount of distress caused by having to wait for a forensic examination. So, sometimes hours, sometimes days, people are having to wait, and what that means is they cannot wash after being raped or sexually assaulted. And that can cause huge distress when you think of what that actually means for people. So those are the two key things that come up for us. I think there's also broader, more general issues that people have raised already this morning about lack of trauma-informed practice. So at the closed session last week, we had one survivor speak about how the male doctor that examined her didn't say a single word during the examination, and how that made her feel. And that's clearly, to me, not trauma-informed practice. So that's a real issue of culture, but also of training of medical staff who are involved in these examinations.
Anyone else like to chip in? Just feel free. You don't need to press your button. Just wave at me, and I will catch it. I will see your eye. Yes, Jen.
Yeah, I would reiterate the access to female examiners. That is definitely something that has consistently come up, as has communication. So I think that falls into the trauma-informed practice. Having examiners who are very clear about what they are doing, when they are doing it, and why. Survivors has told us what a difference that makes, and a non-judgmental approach. I think the way that, because we have SARN in Tayside, the Sexual Assault Referral Network, so supporting survivors who have been through that and them getting that connection to a rape crisis worker from the beginning. They're met with a nurse, they're met by the worker, they have follow-up support as well, has made a significant difference. So.
Gwen.
Also, I mean, what they're telling us is the fact that it's about being able to pause things and actually being able to get some of the information that they need and kind of take stock of where they are before they can decide how they proceed. Seems like something that will make a huge difference. In Highland, that's kind of some of the things that people are telling us. And also for us, some of the concerns are around travel and how they access services in Highland is obviously a big concern. We've had instances of people who've had to be transported from one police car to another police car because it's changed a shift or because it's, you know, covering one area to the other. And all of that can just impact on that whole kind of re-traumatisation as part of that journey as well. So, yeah, just a kind of consideration for.
Okay. Anne?
Just echo everything that's already been said. One thing for our area is semi-rural, so again, the travel. Also, key thing that came forward, women that we did speak to, we asked the specialist agencies to hold focus groups before we responded, was the thing about give me back some control. So the pause and let me say when, how and how fast things go ahead.
Thank you very much. One of the things that was, I think, shocking for me at least last week, because I wasn't aware of it, was the circumstance where somebody who had wanted to report a rape on a Sunday night found that the service was so much poorer than it would have been on a Monday morning. Is that something that's important too for victims to be able to see an out-of-hours service, if you like, or 24/7 service?
I think it should be the case that no matter when somebody's raped, no matter when somebody chooses to access either health or forensic services, they should be able to access that service when they need it. It shouldn't be a two-tier service where if it's out of hours or the weekend where they need to wait overnight in the clothes they were raped in without washing it. I think that's inhumane to expect that of people in these circumstances. I think these services absolutely be resourced 24 hours. I think there's slightly different considerations if it's historic, where there's no immediate necessity in terms of forensic examination, for example, around the more general health responses. But if somebody's just been raped, they should not be waiting days to get an examination.
Okay. Alex.
Convener, great to see you all here, and just to reiterate, you know, our thanks for you being here, for the service you provide. I think that the testimony we heard last week will stay with me forever. One of the things that really struck me about the individual stories that we heard was the lack of consent that takes place sometimes in rape exams. That I remember that one particular example that really stuck with me was that it was a female healthcare professional, but she said, well, we'll just do your smear test now. Didn't ask and just, you know, and did it. And that struck me as horrifying. I would like to think that's the exception rather than the rule, but can you give us an understanding of that?
Jen, do you want to comment?
We certainly, I have to say, over the last, especially 2 years, I would say that actually the feedback in relation to the forensic medical examiners has been very positive, and the experience of survivors in our area, it has been fed back that things have been explained and that it has been more trauma informed. Good. I think we have many experiences shared with us where that has not been the case, but we definitely have seen progress at a local level.
We've seen that nationally as well. We have a feedback protocol in place where we get referrals from Police Scotland. When we call them through the national helpline, we ask them questions where they wish to, about their experience of the police, but also about their experience of the forensic process. It means we're getting really quite quick on-the-ground feedback about what's happening, and I think it's fair to say that over the past 6 months in particular, that the feedback is starting to improve. I think we really are starting to see the impact of the work of the CMO's task force on these issues. That has definitely been reflected, I think, in better feedback coming through from survivors in contact with us. I mean, the one issue that continues to come up is delays, and that really is causing a lot of distress. But we're still, the two issues that are still coming up in the feedback that we're getting is delays and lack of female examiners.
In terms of guidance to health boards, is there anything in addition to those 2 points that you would like to see in relation to examinations?
I do think the point earlier was really well made about links to advocacy services. We run a national advocacy project from Rape Crisis Scotland in partnership with all our local rape crisis centres. The feedback from survivors is that that's a life-saving service, but there is real issues about capacity in terms of funding. Some of our advocacy services have to operate waiting lists, which I don't think is acceptable for services of this nature. So I think we need to look at how to properly fund the health response, but also how to fund the services that should go alongside that. And I would like to say just briefly in the health response, if we're looking at how to resource that, I don't think I should only be looking at what are the number of additional cases through self-referral. What we're asking health to do is to transform the response to rape and to survivors of rape. And I think to do that properly, I think will require a significant injection of resources above just like the number of cases that will be self-referral. Because for me, this bill has two key functions. One is self-referral, but the other, and just as importantly, is putting the responsibility onto health to make it really clear that health has a responsibility to respond to the needs of rape survivors. And that hasn't necessarily happened today. It's been very focused just on the old model of provision of the actual forensic examinations rather than the wraparound care. And if we are going to get those services to a stage where they're not an embarrassment to us as a country, I think it will need significant investment.
Okay. David.
Thanks, Commissioner. Could I perhaps raise the issue of advocacy now, since it was highlighted earlier? I agree with these points, and I think I would echo the meeting we had last week was, I think, harrowing, but I think they were extremely brave, the 10 women that came along. But certainly what I was struck with was the need for this independent advocacy, and you were in the room when I raised the point earlier to the Bill team. I still feel that there should be a clearer point in the Bill about advocacy services. It's not enough that they're there. My sense is they're still patchy and probably underfunded across the country. But what is needed is that survivors or victims need to know about these services, and some clearer emphasis in the bill would probably help. Obviously, the committee have a role and individual members have a role in things like amendments, but I'd be grateful for the other panellists' views on that particular issue. I think I gave you an advert earlier. So,
Gwen.
Yeah, I mean, that highlights exactly some of the issues that we would have in Highland for capacity in terms of, you know, if we have to go, especially as a lot of the forensic exams are going to be carried out more locally. So, you know, it could be, if we're based in Highland and we have 2 advocacy workers, you know, the capacity to be able to go to Fort William or Skye or Wick is going to be really challenging in how we do that. And I think we are expecting that the need for our service and the need for that independent advocacy is actually going to go up somewhat. So, yeah, we are kind of preempting that we're really going to struggle in terms of how we can actually continue to deliver the level of service that we do at the moment. Yeah.
Yep. Yes, Sandy, yes. And then Sandy. Yep.
I think advocacy support should be a core part of the clinical pathway that's been put in place that lies underneath the provisions in this draft legislation. And I think for that to work, it needs to be resourced properly.
Just echoing some of the things that my colleagues have said, absolutely. I think support and advocacy has to be part of the core pathway, but we need to be looking at equity across the country. So looking at where you have issues of travel, rurality, not density of population, and that we're facing a postcode lottery of the services that women actually do access. I think also to be mindful that when we're talking about rape, that we can often be talking about rape within a relationship. So where there's elements of coercive control and that, we've got barriers to women going forward, concerns about what's going to be done with that evidence, who's going to have access to it. So back to my earlier point about women having some control about how they report, who they report to, and when they're able to go into a police investigation. But that we capture the forensic evidence so it's there for when they're at that point.
Thank you very much. Emma.
Thanks, Convener. Good morning, everybody. Because I'm a rural MSP, I'm interested in how do we protect confidentiality in rural areas. And if we're trying to establish a process where there'll be a standardised approach across health boards, somebody in Stranraer could really go to Ayr rather than Dumfries, for instance. So should there be, I guess, a process where people can self-refer to a place of their choice rather than be directed to a place within their NHS board catchment area?
Yeah, absolutely. Also, it might be that somebody lives in one area, but the incident took place in a different area. So where they access that service, in my view, should be determined by their need and their wishes rather than what health board area they live in. I think you're absolutely right to raise anonymity as an issue, and I'm sure Gwen can say more about this. There was particular issues on the islands, for example, in Shetland and Orkney before they moved finally to delivering it locally, where people were having to travel to the mainland for these examinations. And I think the difficulty was, but what people in the community said was that everyone knew if somebody's got in a boat or a plane accompanied by police officers, everyone in the island knew something terrible had happened to you. And if that's not a deterrent to reporting rape, I don't know what is. So I think we need locally delivered services. I think people should not be travelling significant distances, like say from Campbelltown to Glasgow in the back of a police car. I hope those days are over through the advent of more locally delivered services, because I think that's unacceptable. But at the same time, I think there should be some choice about where people go in terms of self-referral. It should be what's comfortable for them, what feels that it protects their anonymity, and what's convenient as well.
Jen, did you want to comment on that one? I saw you were.
No, I would just echo. I think it's challenges that affect us due to the very geography of our of our country. I'm thinking, you know, if we have if there's an incident in Kinlochranach, do you know, and that person has to get to Dundee, there's significant problems there for supporting people to access these services. So I think we definitely have a long way to go.
The local delivery is important. Anne.
Echo what Jen said, because Angus is part of Tayside, but what we're finding are many services located in Dundee, and we're finding this kind of movement almost back to an old region approach, and what that means for women living up in the Glens and Angus and rural parts of P&K. Public transport's horrific, never mind everything else, and everyone knowing everyone. So I would echo concerns around confidentiality and be very keen for, you know, discussions around what could be offered to protect confidentiality of women, because, you know, violence against women knows no boundaries. It happens right across society.
Public transport is a really important point when we're talking about self-referral, because when it's non-self-referral, it's often somebody will be taken in a police car to where the examination is being carried out. Whereas with self-referral, people are generally making their own way there, unless they're being supported by, for example, one of our advocacy workers. And that's why locally based services that still protect people's confidentiality are really important, because somebody shouldn't have to be travelling on like three buses and a long walk to get to a service of this nature. So they must be locally based.
Thank you very much. Sandra.
Thank you very much, Convener. Good morning, all. That was quite an interesting aspect. I'm sure the committee will discuss it afterwards. I wanted to sort of take you back a wee bit to the training for, you know, examiners. Certainly when we heard the evidence, it was quite horrific, and I know we asked questions of the civil servants there, who I thought gave a very good answer into their role in the bill as well. Yep, absolutely female doctors, we were told that. But one of the horrific things was the fact that when it wasn't a female doctor and they had to have a male doctor, then basically they had no empathy, very dismissive, didn't speak, anything like that. That was what the experience was, that the people who spoke to us. Now we're looking at obviously training and well-being and that type of thing. And I just wondered if the panel consider that health boards will have appropriate guidance. That's why I was asking about legislation and guidance, and certainly I'll look up what's on the bill. If they'll have appropriate guidance and funding as well, which is important, to ensure that they have a well-resourced, trained workforce that we don't experience, or what people have experienced before. Do you think there's enough there in the bill to ensure that the examiners will have guidance, will adhere to the guidance, and they'll be well trained and well resourced as well?
Gwen.
I mean, one of the things that we've kind of been discussing is the fact that as we move towards looking more trauma-informed training, is actually making sure that people are implementing that, so they're working in that way as well, so it doesn't become a tick box that people are just doing the training and then not actually working in that manner. There was a whole team of new forensics nurses that came in a few months back in Highland, and we were actually asked to go along and do some training with them, just in terms of the kind of trauma-informed care that we do on a day-to-day basis. And the feedback from the nurses was that they found that, you know, really quite powerful, because again, it was that kind of making it real. So maybe it's kind of making sure there's the formal training as well as some of the more guidance training in terms of actually what we do on a day-to-day basis.
Absolutely. Just to echo some of Gwen's points, I would love in Scotland for us to stop talking about trauma-informed and start moving to trauma-responsive, and actually be delivering trauma-responsive services at a point of need. There's that. NHS training, absolutely. Why are we not making use of the expertise on the ground? You know, those services you said, you heard from Survivor, they are the experts. They are the experts that live with a lived experience. And how do we get the golden thread of that lived experience through the training? By involving the specialist agencies on the ground in either writing and or delivering the training, would be my suggestion.
I think it's in the SPICE briefing, but there's one woman who went through the forensic service who I think really bravely took the time to make an audio recording of what was most difficult about the experience for her. And we've used that in training with forensic doctors and staff, and I think that is a really important point about how do we make sure that people who are delivering these services hear directly from survivors about what was difficult and what maybe made things a little bit easier, because it includes things that people might not even think of. So if you've heard the podcast I'm referring to, the survivor talks about going into the forensic room, and it was obviously used for child examinations as well, and there was a mobile in the ceiling above the forensic examination bed, and how distressing that was. And I think that is what trauma-informed or trauma-responsive practice means, is thinking about the bigger things, but also the small things that could be really, really upsetting to somebody at that kind of time, making sure it's age appropriate, that the physical environment is appropriate, because quite a lot of feedback we've had previously, and I think it is starting to change, is a sense of just there not being care for their well-being. So like somebody's there for a long period of time, they're not asked if they want a drink, they're not offered anything to eat. Like, that's not how you get best evidence for a start from somebody, but it's also, I think what that conveys is a lack of care, and what somebody really needs in those circumstances is a sense that somebody's looking after their well-being. And I think some of these are much broader issues than, the bill is one part, I think, of a much wider package of work around particularly the clinical pathways and the work that's coming out for the specification for these services being set up across the country. So I think that is how we should see it, is what can legislation achieve, but also what else needs to be put in place, and how do we make sure once it is put in place, how do we make sure that that work continues and continues to be funded and delivered properly?
As I say, that raises other, questions as well as, but I think Gwen, when she said, how do we know they're actually, continuing on, and I think what I've took out of the evidence that you've said there is that basically, perhaps, they need to make sure that they are continuing. That would mean asking the women who went through this, and the men as well, if it was satisfactory, and whether that type of thing should be put in the guidance of the bill. I think we need to look at that. And also the fact that, your own selves and others who've got the experience with working and have been survivors for people as well, should be maybe the ones that give the training, who are asked upon giving the training anyway. So that's something I think that we should look at. But I'm talking about that, about giving information and training, but I also wanted to ask about information for victims. And I think that was a really huge issue in regards to the fact that what we heard was they didn't really know what they were going through or anything like that, particularly for getting into some information in regards to what the examination would be in, provide information before it. So I'll just ask you two, I think, straightforward question. What do you think yourselves the information should be provided to victims prior to and after the forensic medical examination? And is there anything else, and I know that it was mentioned here about the bill in section 4, is there anything else that they would like to see in section 4? And that's the part which is information to be provided before the examination on the bill.
Gwen.
Quite a big question, but I'm sure you can write into it. I'm sure we'll get that as well.
I think that's where there probably is quite a lot of opportunity with independent advocacy in terms of if that is a port of call for people, that actually they can lay out what the options are, and make sure that people have all the relevant information, and then it's not linked to services, so then people can decide if they do want to report to the police or if they do want to self-refer, or so it's almost kind of giving people information in advance of that. But I agree as well. I mean, I think how we actually, as this comes into play, how we make sure that people are aware of it is going to be crucial as well. A lot of survivors that come to us have real concerns about speaking to the police or things, just because it's something that they've never done before. So because there's obviously going to be a lot of changes with this, I think how those messages go out is going to be really important as well.
Yeah, I would say so.
Jen?
And I think the messages need to be really consistent amongst all professionals involved in the process. So, and I think the point about reporting is really important. So, if they're speaking to somebody prior to, say it's a self-referral, and they're speaking to somebody and they're told about being able to make a decision about reporting in their own time, this is giving them some space. It's very important then that every professional involved in that communicates the same messages. Because I think that's why people are opting for self-referral, is that it is giving them that space, and so it's quite concerning sometimes that there's feedback that then they feel a certain amount of pressure. So I think that's quite
information. I think as well as professionals being well informed to talk people through what we heard, I think really clearly from the survivor session, was that people just were not in a place to take information in. This is maybe happening like in the hours immediately following a rape or sexual assault. Somebody's likely to be traumatised and in shock. They're not going to take in a lot of information. And I think going back to the point about feeling some level of control, how do we create some sense of control throughout this process for somebody who's had all the control taken away? We need to make sure that they get enough information to give informed consent to the forensic beforehand. I think that should be written information. I think that has been developed through the work of the CMO task force, but also information to be taken away that says, this is what's happened, this is what's going to happen next, these are the samples we've taken, because someone with the best will in the world, they will not take in that information that they've been told at the time, or they're unlikely to retain it. We've had survivors tell us they've got away with lots of different leaflets. They can't remember who gave them what, or what's going on. So I think there's some work that we're doing at Rape Crisis Scotland, working with the government to do an information booklet, pulling things together for somebody immediately after the forensic examination. And I think that's really important, that people have clear information that's informed by survivors' voices about what information they say they need, and it's written in a really accessible way. And I think that, combined with training for professionals that can talk through, I think that's how we meet the information needs.
My colleagues are saying, but one thing I'd add is we've kind of got an example already with the Domestic Abuse Disclosure Bill, with amount of information that went out, flowcharts that were created. Police Scotland put an awful lot of information out there so that people knew the procedures and timelines and that ahead of, should they request the disclosure. Well, I would suggest something similar, so not waiting to that point where a woman has been raped and is going forward, but actually what would be, what would be the process, what would be the timelines, who would be involved, keeping it to the KISS principle, keep it very simple, keep it straightforward, using all the media. Social media is a massive influencing platform, so actually making use of all the media possible to make sure that everyone's getting a consistent message about what that would be. And that could then also be part of informed kind of an overall communication strategy, if you like, that's including what is the content of the training, etc.
That's correct. No, you okay? David, did you want to come in briefly?
Could I just raise, convener, a sort of wider question at this juncture? We know from the statistics and the discussion we had last week with victims that sexual offences have low reporting and low conviction rates. I mean, I was interested to hear from the panellists about whether anything in the bill would affect these factors positively. Obviously, I appreciate this is a health bill, not a justice bill. But I think the point I made earlier was that government should be looking at, joined up thinking across the portfolios, and it would be useful to hear from the panellists today on their views.
Certainly, certainly, but I think briefly, because we have other areas we need to, but I think it's an important question.
Yes, I think one of the issues today and why I think we're so behind in our response, forensic and health, in terms of sexual crime is that there's been a gap between health and justice, and this issue has fallen in that gap, and I think we need to be really, really careful that that doesn't happen again. I think this bill will really help with that because it places such a clear responsibility onto health. I think the bill has the potential to deal to some degree with the levels of under-reporting, because if somebody maybe currently doesn't feel able to report to the police, they can't get a forensic examination unless it's in the Archway or Tayside areas. What this bill will mean is that it won't be a postcode lottery anywhere in Scotland. You can access forensic examination without reporting, which means that evidence won't be lost, which may lead to more reports. I don't think we'll be talking significant numbers. I think there's a lot of different data from different countries that have self-referral about how many of those self-referrals actually go on to report to the police. So I think we should be realistic about what this bill is going to achieve. But even if it's small numbers in terms of reducing the level of under-reporting of rape, I think it's a very, very important bill, because I think everybody should have access to self-referral across the country. But also, I think what it does do is put such a clear responsibility onto health to coordinate responses, that I think that really is one of the strongest things that's in the bill.
Oh.
Echoing everything Sandy's just said, I'm going to put my day hat on for a second. I'm here as the chair of Angus Violence Against Women Partnership, but in my day job, I'm Executive Director of Angus Women's Aid, and we do know the significant number of women who disclose to us and every other women's aid service across the country the level of rape and sexual assault as part of the domestic abuse that they experience. What this bill would allow is those women to go forward and self-refer, and what we will do as a country is get a better idea of the scale of sexual assault and rape. And now, in Scotland, now, I echo what Sandy's saying, I don't know how many of those will convert in the short or medium term to prosecutions, but we'd have a better idea of what the social issues that we need to deal with.
Okay, thank you very much. Jen, sorry.
Sorry, I would just say, working in an area that does have self-referral, it might not be that we have significant numbers of survivors that have then gone on to report, but there have been survivors who have gone on to report, and there has, been people that have got justice after that, and I think it's about giving people choices.
Okay, thank you very much. Brian.
Thank you, Camilla. Again, welcome to the panel, and I just want to echo the sentiments of some of my colleagues today, all my colleagues today, around the evidence that we heard last week. Very harrowing, very brave of them, and very necessary. We hear that, and it was just to echo what my colleague David said there around, we're discussing a crime that's underreported with low levels of conviction. So I think the potential of getting this legislation right can't be overstated. And funny enough, I think there is a serious health implication there around women's ability to, or men for that matter's ability to be heard around their mental health implications and physical health implications. So I don't think it's as simple as separating justice and health. I think they both are intertwined. But the question I wanted to ask is around people's ability to self-refer when they have a lack of capacity or additional support needs, including children or older adults or individuals with mental disorders, intellectual disability. Are there issues around their ability to self-refer?
Who would like to go with that one? Gwen?
Yeah, I think there are going to be issues, but also I think we need to take consideration within that about what are vulnerable adults, because actually that might be slightly different in terms of, if we've got somebody who's previously been traumatised by something and then is being re-traumatised by an assault that's happened, actually there's going to be real issues in terms of how they process that, but they might not necessarily be seen as somebody who is recognised as a vulnerable adult. So I guess it's having some thinking around what do we actually mean by vulnerable in that. But yeah, I don't know how we better support some of these individuals, but I think it's definitely something we need to make sure that they have somebody alongside them on that journey to make sure that they're having true independent kind of support throughout that as well.
Sandy?
If I could come in there, maybe to deal with the issue of children first, because I think there's been quite a lot of discussion, understandably, about is the age right in terms of self-referral for 16? Should it be 18? Should it be under 16? And I'm very sympathetic to the arguments about extending it to under 16s, but I think probably the bill has got it right in terms of it being 16. I think the point that Alex Cole-Hamilton made is absolutely right. We're talking about access to services of people that are really vulnerable. Children are obviously very vulnerable, but we definitely don't want to exclude them from accessing something that might assist in these circumstances. But I think in reality, if somebody under 16 was to self-refer, I think in almost every occasion the clinicians would decide they needed to call an interagency discussion. And if they do, that is not self-referral. So what I'm wary of is offering a meaningless right to young people. I think there is no point giving a right if it's not meaningful. And as I say, I think in almost every single case, the clinicians would feel they had to notify social work, and who would notify the police.
So would you lower the minimum age for self-referral?
I think the bill, on balance, I think has got it right. It's 16. Unless clinicians were able to assure us that they felt they could offer it meaningfully for under 16s, because if they can't offer it meaningfully, there is no point in doing it. I think we do need to look at how do we provide services to young people experiencing sexual abuse. There is a huge gap for advocacy support for young people, particularly under 12 to 13. Our advocacy services work with 12 to 13-year-olds and over. For children under that age who've been sexually abused, there is such a gap around support and advocacy, particularly about the court process as well as this, that I think there's a lot of really important related work around Barnahus that should be looked at, or is being looked at, that would run alongside this bill. But I think this bill really has quite a narrow focus, and it's about these two specific issues about making clear health as its responsibility and introducing self-referral. So that's my views in terms of the age limit. In terms of capacity, more generally, I think we shouldn't be restricting access to this service, to self-referral, unless it's absolutely essential. I think we need to be careful not to be paternalistic or make decisions on behalf of people unless they genuinely are unable to consent to a medical procedure. I think clinicians are very experienced in this in terms of assessing whether or not somebody has the capacity to consent to medical procedures. I think that's even more important in these circumstances, and I do think the role of support agencies can be really helpful in helping people navigate that process. So services like ours, but also services like People First, we work with people with learning disabilities.
As I say, I'm here today as chair of Angus Violence Against Women Partnership, but we shared our response with Angus Child Protection Committee for comment, and they were in favour of perhaps a stage 2 where we looked at under 16s for some of the reasons that have already been outlined. And one of the things that we're concerned about is the number of young people, young women, 14, 15, who are disclosing but not reporting rape and other sexual assaults in their own relationships. And that was why we wondered if our viewpoint was that perhaps there should be a stage 2 to this whole change of process, where that was brought in, where we looked very carefully at how can we give those guarantees that it is actually a self-referral, that child protection guidelines are being followed, bringing in the GILIC competencies, etc. But at stage 1, not yet, but possibly moving on, because we wondered if we had a ticking time bomb.
Am I right to think you're talking about a second piece of legislation? Is
Yes.
that what you're saying? Yeah.
Yes.
Understood. Yeah.
Yes, a following
Yes, yeah.
I think there is also a really important piece of work to look at why is it that young people and young women in those circumstances aren't reporting. And I don't know that self-referral is in itself going to fix that. I think there is a wider issue about cultural attitudes towards sexual violation, what's happening in schools, what messages young people are getting about whether behaviour is normalised, whether behaviour is acceptable. But also, I think it's about our justice system, about do people have confidence in our justice system. And if you look at how people are treated, if you look at our conviction rate, how many cases never get to court, you can understand why young people are saying that this isn't for me, and that's beyond the health committee. So I think self-referral is important, but also I think we need to be realistic about what else needs to happen in terms of reducing under-reporting, and it's not all going to be dealt with by this bill.
I'm Brian.
The other thing, this point that's been raised, I wanted to discuss is this idea of the implications of socio-economic deprivation, and I think Anne, and you said that you're quite right to say that this is a crime that perpetuates across the whole of society. So we've got to be careful we don't pigeonhole this. But I think what I would like to ask is around access to service, around the socio-economic deprivation, and whether or not we should have this ability to target better.
That I'm aware of that sexual crime is any higher in working class communities than in middle or upper class communities. So for me, I think it's just about making sure that the services are available and accessible to everyone. I think we should be proactively trying to look at how do we remove barriers to accessing the service, and one of the ways I think of doing that is to look at, so with self-referral, if somebody's having to travel themselves, is there the facility to refund their travel costs, or like to arrange taxis, or looking at what are the practical barriers to people accessing services in general, but also people are living in poverty, what are the barriers? And often those are financial barriers, there might be childcare barriers, what do they do with their kids when they're coming to get the examination? So I think there are things I think that's a really important thing to think about what can we put in place to make sure that there aren't financial barriers for people accessing the services.
Yep.
Again, I'll just echo exactly what Sandy's saying, but I think picking up a point one of my colleagues made earlier is also about the confidentiality. I think, we need to make sure that services are accessible to all women.
Gwen.
Yeah, I mean, I'd quite like to just echo that it is about looking to see how we can remove some of the barriers for people to access. I mean, because we were talking about some of the culturally, sometimes it's not, people are not going to come forward because of this kind of cultural differences, and how we make sure that there's methods that people are more aware of the service in terms of that. But also, I had a chat within some of the staff in terms of people that they've supported previously a few days back, and we had a conversation around homeless people who are assaulted very regularly, but actually are limited in terms of how they can access, quite often they don't have a phone, so they can't phone a service. So it's kind of making sure that there are different accessible routes for people and how they're supported through that as well.
Good point. Thank you very much. Excellent. I think, Emma, over to you.
We've covered a little bit already about wraparound services, complete support. I know that the place in Dumfries is planning to relocate sexual health and psychology right next to the sexual assault centre, so that there is a proper engaged wraparound service. And for me, there's major challenges in the rural area, and I know we've covered we need to access psychology, it has to be a wider service. If we then have a better engagement, then there might be improved self-referral rates. We did hear from people last week that it might have been useful to have something recorded in the case notes, so that if I was, for instance, going to have a smear test, that somewhere there was some red flag that said this person is a survivor of rape. And so and that's so that they don't have to retell their story every time, or when you go for whatever blood test, I'm afraid of needles, that kind of thing. So what is the further feedback about what needs to be in a person's medical record, and then who accesses it? How do we protect confidentiality? And again, it's in rural areas, everybody knows everybody.
Gwen.
Yeah, I completely agree. I mean, I think there's some real confidentiality issues in terms of rural communities, because actually, anybody working in the service, depending on who can access it, often might know the perpetrator as well. So it's recognising it's not just maybe even about knowing the survivor who's been there for the examination, but actually they may know the perpetrator that's been involved as well. So yeah, I think we would have to have some very clear consideration about how people access that information and what's relevant to be storing it. But yeah, it would make it so much more powerful if people didn't have to retell their story every time as well.
Sandy.
I think there was feedback from the survivors about, I think there was an assumption from them that their GP would know, or that if they went for a smear, the nurse would know, and that was distressing that they had to retell numerous times. But I think it just gets back to consent. I think it would be helpful to introduce, as part of the clinical pathway, to look at asking somebody really clearly, would this be helpful? Do you want us to do it? Give them a chance to think about it if they're not sure. Because I do have some anxieties about people's medical records, because we do see them being brought up during the course of rape trials, which I think can be really distressing for people. And if they knew that was a possibility, they might not consent to certain things being in their medical records. I think the NHS, in my view, could do more to protect the confidentiality of people's medical records going through criminal proceedings. But that issue aside, I do think we should be considering asking survivors as part of the clinical process, and as we coordinate that pathway, would you like us to put this on your record so you don't need to retell your story? And then somebody can make a choice about do they or don't they want that to happen.
Presumably would be at the point of the examination, effectively.
Yeah, or as part of the kind of immediate follow-up. Yeah.
Anybody else? Jen, yeah.
To get the information right with that. So exactly what would happen with that information? Do they have the right to retract that information? I think that's earlier when we're speaking about what information people get. I think that would be vital for that.
Just a thought about support for people, like Dave Stewart mentioned about advocacy. How will the bill support people of ethnic minorities that might have English as a second language, some challenges about accessing healthcare, whether it's about rape and sexual assault, or just the fact that you're going to a healthcare professional in the first place. So there's going to be challenges in some of our Black and Asian minority groups as well.
It's one of the things that we're looking at in the self-referral subgroup that I'm chairing through the CMO's task force, is about making sure that any information that's being produced is accessible across all our communities, because I think that is a really important point about making sure that anything that we're producing can be used by any community in the country that might need it.
Okay, thank you very much. David Torrance.
Thank you, Convener. All the written evidence to committee has highlighted the need to raise awareness and promote self-referral. How do you think the option of self-referral should be publicised, and who should be responsible for promotion of self-referral services?
Jane?
Well, I think it should be a shared responsibility. In terms of, I know locally, in order to promote it, we went to social media, we went to posters, GP talks, speaking to local hospitals as well has been done, and it has been a shared approach between NHS partners, RASAC in Dundee and Perth, Rape Crisis Scotland and the police. So
that's the word, yeah. Sandy?
Self-referral group is about information, but also an awareness raising campaign about, once we're clear about what the routes are going to be into the self-referral process, how do we make sure people know about it. I mean, I think part of the difficulty is it is the kind of thing that you probably don't know about or aren't going to inform yourself about until you're in those circumstances. So I think an awareness campaign is important, but I think it's probably going to have a limited impact, and probably the most important thing is making sure the services that people go to straight after being raped, if it's not the police, that they know about self-referral and how it's accessed. So often where people are going, if they're not coming to a service like Rape Crisis, they're going to somebody like their GP. So I think that probably is going to be one of the most common routes in, is through frontline healthcare workers, either A&E or GPs, and making sure they know about how somebody can access it. Also, I think looking at online, so at the moment, if you go into like any health board site or NHS 24 and type in rape, like, I don't think anything comes up at all, because it's not really been a core part of health delivery up until now. So I think we need to look at online information, which is part of what we're looking at through the self-referral subgroup, is what information can people access online. So if somebody's just been raped, maybe they go online to say, like, what do I do, where do I go? We need to make sure that information that's available is accurate and points people really quickly in the right direction.
Because of course the risk with online is that you get bad
Indeed,
advice.
indeed, yeah, indeed.
So NHS branded and provided would clearly be
absolutely.
helpful. Yeah. David, did you have any further?
Just about the public services and that right pathway of self-referral, how do we actually engage with the public services to make sure they're all aware? Because as you say, sometimes they'll be a first port of call for anybody who has been raped.
I think that this is, I think, for the CMO's task force to make sure that through all the health boards that they are cascading that information down so that all frontline workers have the information they need if somebody has just been raped. I mean, particularly for GPs, I think a really common protocol for somebody that's been raped that haven't reported to the police. I think we need to make sure GPs have this information, but also that they have written information they can give somebody. I mean, I've spoken to people before that say, oh, I didn't report, but I saw my GP, I hope he's kept the samples. And people just, I think in that situation, they just don't take in what is actually happening. So we really need to make sure there's clear written information being given to people, both through the forensic pathway, but also at that very first point of contact if they're in touch with their GP.
Yeah, wherever it might be. Yeah. Anyone else? Okay, thank you very much. Emma.
Thanks. I'm assuming like nursing schools for teaching nurses would be important to pass on information as well. Yeah. Okay. And Sandy, you mentioned the retention of evidence. One of the issues came up about like how do we, well, what's the best way to retain samples? How do we make sure victims or survivors are informed about their samples? Because again, it's about choice and control and allowing people to then make the decisions about where they want their samples to be. So what are the main factors regarding retaining samples and other evidence that would be important to victims? And are there potential issues that need to be addressed?
I think people definitely need to be given clear written information to take away with them that says that this is what we've collected, this is what we're going to do with it, this is what we'll tell you, and this is when it's going to be destroyed. Because I think to say to somebody, like, we need to decide what the retention period is going to be, leaving that aside for one moment. Somebody's not necessarily going to have that at the forefront of their mind that if I don't report to the police within 2 years, this information is going to be destroyed. So we really need to look at how do you make sure that when somebody's consenting to this in a very traumatised situation, I think at the very least there needs to be a check-in a little bit further down the line. You don't want to pressurise somebody into reporting, but I think you need to make sure that somebody knows that their samples haven't been tested. I think some people assume that, or because it's been taken, it will be tested and they'll come back to me if there's been a hit. That's not how it's going to work. So I think it's about the provision of clear information so that somebody knows exactly what the situation is, because that's the only way to enable informed choice, is to have people properly informed at the start about what's happening with their samples. And I think that does need to be verbally and in writing, because the people are unlikely to take it in and retain it.
Yes, the written point, isn't it, that it gets taken away? Yeah. Emma?
I think like one of the things I learned last Friday was about a named nurse would be applied, right? And that named nurse would be the person that would check in, and that might make it easier to not trigger the 1 year anniversary or the 2 year anniversary of like a horrific event. So with the development of forensic nurses, is that something that it might be seen as a good idea to have like a named person, a named nurse?
Absolutely. I think the forensic nurse pilot or test of change is a really, really important one that I think could transform our services across Scotland, but even in areas that aren't running the pilot. So the pilot's about the nurses actually doing the examination. Even in areas that aren't participating in that pilot are still involving nurses, often a kind of a supportive and coordinating role as part of the forensic examination. So I think across the country, I think people should be given a named nurse or a named contact who's responsible for their care and who can do that follow-up. And I think, again, it's with consent. It's saying to people about, you know, come back tomorrow, come back in a few days, this and this will happen in terms of your testing. I'll check in with you then, and then, like say, maybe I'll phone you up in 2 months, see what you're thinking in terms of your samples. So I think as long as somebody's clear what's happening, they're consenting to that contact, it won't feel like pressure. And I do think that check-in is going to be important in these circumstances.
Should the bill determine the length of time that samples should be retained, like 1 year, 2 year, 3 years? Because we've heard in the previous session that there's flexibility in other places.
No consensus, I think was the phrase that was used. There's no consensus in the period. Jen.
And from what we know, survivors would ask that they're kept for as long as possible. Locally, we have it's up to 8 years that we are telling women.
Yeah, and that would be a general view. I take it from the nods around the table. Excellent.
I guess the final question is, like, how should victims be advised that their evidence is about to be destroyed by a health board?
You need to know in advance. I think getting a call out of the blue saying, oh, your evidence is going to be destroyed next week, I don't think is acceptable. They need to know and have in their mind that this is the time frame that is going to be applied in their case, so that they're able to process what that might mean and make a decision. I think some of it is going to be for negotiation at an appropriate point about what do you want us to do, because some people might say, I just don't want you to contact me at all, just destroy it if I've not come back to you. Other people might say, no, definitely get back in touch with me because I want some support around the decision. I think it probably goes alongside if you've got advocacy workers as part of, or rape crisis as part of that clinical pathway. We can be doing some of that support with people as well, about just reflecting on where are you with this, how are you feeling about it in a way that doesn't feel like pressure. And what do you think?
Gwen?
Yeah, as well. I mean, I was just going to add to that, I think as well, if having an advocacy worker is part of that journey and actually being able to kind of help you navigate through that and actually make sure that you are able to discuss, because I guess if they're aware of the timescales as well, if you've been the, you know, part of that process, then they can almost prepare you to have to start to think about making that decision. But I think it all just comes back to about putting some of the control back into the survivor, in terms of, you know, they've come through a situation where they've lost all control, so actually making sure that they're informed and being able to give consent and permission to how their information is stored and for how long throughout that process, you know, is really important. So, and possibly advocacy workers throughout that is maybe the way that it can better support somebody, or the forensic nurse if that is a kind of named person as well.
I mean, for me, it sounds like Women's Aid and Rape Crisis is absolutely essential to all of this, so that we don't want to take from one person and who's in advocacy and just say, okay, now we've got these new forensic nurses that are your named nurses. There has to be this continued engagement to whatever service people choose to engage with, because they might choose one way rather than another.
Choice, about giving them choice. You know, if it's somebody who's decided that they don't want support from Rape Crisis or from Women's Aid, but actually, you know, are quite happy to have that contact from the nurse, then maybe that is their preferred route. But maybe if it is individuals who have chosen, you know, Rape Crisis, then that is their route. So, yeah, I think about giving them choice back is important as well.
Anne, did you want to add? Yep, just
yeah, it is that about choice, and I suppose the other thing is about the women having the right to see, so back to having the choice for the survivor, about a look-back contact that says, destroy my samples now. You know, I've made this decision, I've reflected and I've made this decision, I don't want to report, destroy my samples now.
Okay, thank you very much, that's clear. Yeah. Thank you. Brian.
I think what to look at is the implementation of this bill. There will be a cost, obviously, to that. And within the financial memorandum, the bill states there will be no direct cost to local authorities, and also says that third sector organisations will play an important part in raising awareness, but the cost to the third sector of supporting the implementation of the bill will be modest. I have to say there's two words that concern me a bit there. One is direct costs to local authorities, which implies to me there will be a cost somewhere or other. And the other word there I don't like is modest. And so given the importance of the third sector within what we're discussing today, the huge importance of the third sector, and also given the financial pressures that already exist on the third sector, I wonder if you would like to comment on the financial memorandum suggesting that the sector, and supporting this, the implementation of the bill, the costs will be modest.
Gwen and then Jen.
I suppose coming from Rathside and Covering Highland, you know, we probably don't feel that it's going to be modest, because if we are going to have to start extending that to more, you know, supporting people in more rural communities, then obviously our geography in itself is just going to increase the travel cost, and actually the staff time costs in terms of that are going to be much more than modest, I would say. So I think we do have some real concerns about how that would actually look like in terms of our service delivery.
Yeah, I would agree with that. I don't necessarily think the costs are modest, and I wonder what that would look like. I think for us, having been such close partners in the self-referral so far, we would definitely want to keep that, and we would definitely want to be one of the key partners in moving that forward. But that will come with additional need to resource it, because our capacity is limited with what we can do, because the pilot is just been done within existing resources, which is a challenge for, obviously a significant challenge. And I know, just going to what somebody mentioned earlier on about the importance of being able to have a hot drink and being able to have access to clean clothes, that is something that we provide, and that's because we approached one of the local supermarkets who donated to the service to enable us to provide these things. So it's about being creative as well, I think, with how we resource these.
Anne.
Definition of modest. Exactly what that means. Yeah, I think that's being somewhat optimistic. So speaking for Angus, we have no dedicated rape crisis service, and that is the same across many parts of Scotland. So that's not a modest implication. What we do have, and I'm sure as many other parts of Scotland have, is that Rathsack and Dundee do offer a very short part-time outreach service to Angus that Women's Aid works very closely with and gives office space and what have you to reduce costs and all the rest of it. So I think the implications are significant as opposed to modest. I don't think that third sector is not up for the challenge, but we can't tackle the challenge without resources.
I think it partly depends what model of service delivery that we're talking about. I think if we're looking at a model of service delivery that was designed to meet the needs of survivors of sexual crime, I think the rape crisis support should be integrated within that model. So that's what we're looking to do in Edinburgh. There's going to be a new centre opening up, a new multi-agency centre that responds to people's needs immediately following rape or sexual assault. And we're going to have a dedicated advocacy worker based within that centre. That then means that I think sometimes people don't care who is delivering the service. What they care about is that the service they get is the right service, and it's for us to coordinate those services behind the scenes. And I think that this is an urban model. It will be different, I think, in rural communities, but this is what I think we should be looking at, is the delivery of coordinated services, looking at what does the evidence tell us about how do we meet the needs of somebody who's just been raped or sexually assaulted. And that's been funded through a different pilot, a VRI pilot, in terms of visually recording somebody's statements to the police. So it's not been funded through this stream of work, but I do think if we're looking at a model that integrates rape crisis support within the service, which is what we should be looking at, including looking at where are the gaps, because we don't have an advocacy worker for Mourie's the only part of Scotland where there's no advocacy worker. I think probably the costs are going to be more than modest. I also think the costs are going to be more than modest for the health service if they're going to do this properly.
And for local authorities, is that an area you have a view on? Brian raised the question of direct versus indirect costs. I'm not sure of this. any expertise on the table from a local authority point of view?
I mean, it's primarily going to be health and third sector and police that I think are involved in the delivery of these services.
Brian and then Anne.
Just want to clarify what we're discussing here is the implementation of the bill. I mean, Emma Harper raised the issue of dedicated healthcare professionals required within that, but also the integration with the third sector and resource the system to make sure that's what we're talking about here, really.
I think costs to local authorities would be perhaps around training. And some of those would be one-off costs. Yeah.
Okay, thank you very much. As you perhaps heard at the end of in the course of the previous evidence session, the question was raised around monitoring and evaluation of the bill once it's in place and the changes that it introduces are in place. And I wonder if you have views on that, and in particular, what information from the point of view of your own organisations and of victim support organisations in general, what information would be useful about the rollout of the bill and its effect in practice?
One thing the bill is going to do is finally implement the provision in previous legislation relating to choice of gender or choice of sex of the examiner, which has never been able to be implemented because we have never had enough female doctors or female medical staff to do that. And I think that's going to be really crucial to monitor that implementation. I think we need to know how many times is somebody offered a female doctor and how many times are they able to get a female doctor. So I say that this is the single most important issue that people are raising with us. So we definitely need to have the data to see whether or not it's working. Also, we want to know that this isn't part of the bill, this is more the general CMO task force. I think we need to know about delays, about how long are people waiting for examinations, because that's going to be really crucial in terms of monitoring. But also, I think we need really rich information about self-referral. Where is it taking place? What are the timeframes around how long are people having to wait for it from being asked for it? What is the what they call the conversion rate? How many cases of those are going on to do a report to the police? What then happens with those cases? Is the evidence that's being collected sufficient? So I think given this is relatively new for us in Scotland, although it has been happening in Tayside and Archway, there's been quite small-ish numbers. So if we're introducing this for the first time nationwide in Scotland, I think we do need really, really rich information. And I know a lot of this work has already been looked at through the CMO task force about data collection. That we need to have this in place right from the very start of the bill being implemented and having a clear review to make sure that is implementation actually being effective.
Last Friday I heard that depending on when the events happen, 60% of the self-referrals happened on a Wednesday between lunchtime and 5 o'clock at night. Very, very small numbers, though, so I think it is really important that we monitor the data. And I agree that we need a 24/7 support because people might choose to self-refer, obviously out of hours. But it is interesting to look at when an incident happens and then when does the self-referral occur. But that wee nugget of data I thought was really surprising when I got that information.
The feedback we had from survivors at the closed session last week talking about is, like I think, as you said, convener, that Sunday seemed to be a particular issue. If you speak to a lot of the providers, they say, oh, there's hardly any demand sometimes for out-of-hours service. And to me, that says that there is something going wrong in the system somewhere, because survivors are saying to us, we need to wait for these services and it's intolerable for us. Then you have some providers saying, oh, but there's not that much demand. So there's something there about the process by which people are able to access these services that isn't working, I think, at the moment.
Gwen.
If there's something around collecting some of the kind of more qualitative stuff in terms of people's experiences to make sure that actually there is a kind of similarity across the country. In terms of, and I'm thinking even in terms of Highland, you know, the experience in Inverness could be very different from Wick, or, you know, it's actually making sure that it's that equity that people are able to access the same service across and what their experiences. So maybe some of that kind of softer capture would be really useful as well.
Jen.
Yeah, I think what we've Helpful is relatively regular meetings with ourselves, the police and NHS, specifically looking at this and speaking about some people's experiences and reflecting on that feedback has been helpful.
Something you would want to continue under the new arrangements. Excellent. Thank you very much. Is there anything else any of the witnesses has not said that they're itching to say before we wrap up this section? I'm sure we'll be hearing from a lot of people as we go forward with this legislation. Sandy.
I wouldn't mind commenting on a question that came up for the previous panel about should the provisions of this bill be extended to child offenders or alleged offenders. And while I think that's an important issue, I do not think it's for this bill. I think this bill is very clearly about victims of rape and sexual assault. I think it's really important in terms of the guidance for forensic integrity that happens in a separate location at a separate time, wherever possible, from the examination of the alleged perpetrator. So my strong feeling would be that this is not for this bill. I think it's important work, but I don't think it's this bill.
Thank you very much. Can I thank our witnesses for your evidence today? That's been very informative, very helpful, and much appreciated. We'll now suspend briefly and we'll resume in public session in 3 or 4 minutes' time. That would be very helpful. Not quite. Yes. Thank you very much. We now move to the next item on the agenda, which is consideration of petition PE 1710 from Edward Archer on community hospital and council care home services in Scotland. The petition calls on the Scottish Parliament to urge the Scottish Government to review the provision of services for the elderly and long-term sick in community and cottage hospitals, as well as council care homes across Scotland. And I'd be interested in any views from members. Clearly, this does relate to the inquiry on social care, which we are currently undertaking, but I wonder if any members have any views on the specific points in this petition. Emma.
Thanks, Convener. It is timely that this is coming to committee right now, especially because we've started the social care inquiry, and what we heard from the government about what they're doing to look at aspects of social care as well. I think how do we incorporate this into our social care work plan that we're already undertaking?
I certainly think it's relevant. Brian and then David.
Well, I think yes, it's completely relevant to what we're trying to do just now. But also, I think it's not just about community and cottage hospitals. It's about the whole care, because we're moving from secondary to primary care. We're moving care into the community, and how that impacts on the whole system. So I think looking at this in isolation won't actually give us the full picture and the full answers that we're looking for.
Yeah, I think that's fair, David.
Referred to the health spoke committee because I felt you could give it more in-depth inquiry into it, and with your inquiry coming up, it'd play a vital part in it, so I'm happy to.
Okay, I think that's generally agreed. I mean, it is notable, one of the things which we will want to do is to use the evidence that's come forward with the petition to inform our inquiry. For example, some integrated joint boards use cottage hospitals as a step-down intermediate facility for people leaving acute care. Others don't, and clearly that's relevant to what we think should happen going forward. But if colleagues are so agreed, we will take account of this petition as part of our social care inquiry, and we'll inform the petitioner accordingly. Is that agreed? Thank you very much. We'll now move into private session.